Hi, everyone. Can you guys all hear me okay? We're going to get started. I know there's probably more people in the back starting to come in. We want to try to keep on time so we have enough time for our presentations and questions afterwards if there are any. My name is Denise Nicholson. I'm an NSWOCC and I work here at the Moncton Hospital, and I'm also the Atlantic Director of NSWOCC Canada. And this is Kathy Harley. Want to say who you are, or do I?
Hi, I'm Kathy Harley. I'm the CEO of Nurses Specialized in Wound Ostomy Continence Canada, and I'm thrilled to be able to be a part of this educational event.
She's a big deal too. It's that she's here. We're so excited that she's here. We're very excited that she's here today. She doesn't like many accolades, but we're going to shout her out a lot. We also have Troy online. He's managing the online thing, and then Melanie's in the back, and she's going to be managing some of the questions that come in online as well. So Kathy's been did you just say this, that you've been the CEO for 20 years? And it's a pretty important thing that she's here tonight. So I am going to today, because she is retiring at the end of our conference in May. So that's why we're very excited to have her here, all of us members of NSWOCC Canada from the East Coast. I do want to mention there's everyone that's special is here, absolutely. But we have Dr. Stacy that's here in the front that's going to be presenting for us in a little bit. And so we're really happy to have him here very much. And then we also have Jeanette Pellerin. I'm trying to see. There you are. Hi, Jeanette. We're so happy you're here. She's VP of Operations with Medavie. And so everybody that's familiar with New Brunswick, we have the extramural program, and we do have Mandy Millay here, who's an NSWOCC that works at extramural at the Driscoll. And so, yeah, we're just happy to have you here too. Want to thank everybody that's presenting here today. Everyone should have an agenda, and we just have some few things that we're going to go through. And we just want to thank you all for being here today. Troy is currently doing a Zoom poll to see where everyone is, but I just want to know if everyone could kind of put their hands up when I ask where you're from. Who's here from New Brunswick? Okay, so there's a good number here. Nova Scotia. Oh, good. Oh, you guys are front and center. PEI. I know some. We got 3 from PEI. Woohoo! Newfoundland. No, we don't have anybody from Newfoundland. Oh, okay. We have one person from Newfoundland here. And then anywhere else I did not mention? No. Okay. And then Troy has his polls here. And so everybody's been putting into the poll there. We have 4% from Alberta, 2% British Columbia, 35% from New Brunswick. We have 4% from Newfoundland. Where else do we have? 19% from Nova Scotia, 2% from Nunavut, 21% from Ontario, 6% from PEI. There's our PEIers. 4% from Quebec, 2% from Saskatchewan. Oh, and 2% international. Wow. Troy, did they say where they're from internationally?
I'm not sure, but if you're online here, type in the chat where you're from. If you're internationally, welcome.
That's pretty impressive. Okay, so we have also available today, if you guys, is it advancing? There. We have an application, an AI program called Wordly. So if anybody does want to have any translation in French, you can scan, or is it any language, or is it just
any
French
language?
Yeah, so you can scan the QR code. We'll give you guys a second if you want to try that program, and you can use that along the day. Anybody? I'll wait a sec for people to scan it. Is it good? Okay, thank you. See, Troy, this is why you told me that the online attendees will see me. First of all, I want to read our land acknowledgement. We respectfully acknowledge that New Brunswick is situated on the unceded and unsurrendered territories of the Wolastoqey, Mi'kmaq, and Pescatawamukati peoples. We seek to repair and rebuild meaningful relationships with Indigenous peoples and honor these lands which hold the hopes of future generations. What do you, Kathy?
Putting on an education day takes a lot of work, and I wanted to start by thanking all of the volunteers who contributed to making today a success, led by Denise Nicholson. If you could stand up and be recognized.
Oh,
They're they're at the back. Joan Pennell and group,
you
they're
guys
they're all at the back. Thank you. It's really important to hold events like this and to hold education. And it's important for a few reasons. Number one, it's a great place to learn. You're going to learn new ways, new techniques, and be able to apply them to develop new skills in the clinical setting. So that's very important. The second thing is there is an exhibit hall, and it's over in the Kent room. So you walk across the registration and straight over and up a set of stairs into the exhibit hall. It's really important that you go around to every single booth because you're going to learn about new products and technologies, again, that can help support you in achieving patient outcomes. And the last thing is networking. It's sharing best practice. You can learn a lot from the people sitting around your table, people that you engage in conversations with, and you can meet new friends. I remember in 2004, I attended a conference in Kelowna, and I sat beside a nurse on a bus, and we started a conversation, and we became best friends, and we're still best friends 2 years later. So I think it's a really good way to build friendships and your network. I also wanted to mention Swan Week. And so we'll just go forward. So as you know, we have our nurses specialized in wound ostomy continence, and we also have skin wellness associate nurses who are LPNs and diploma nurses. And we launched this program we developed it in 2020, and it was fully launched by 2021. And we now have over 400 SWANs across Canada. But what I wanted to call out is in New Brunswick, you are leading the development of the NSWOCC SWAN team. And I just wanted to call out Mandy Millay and Matthew Brock for the excellent work that they've been doing in extramural in New Brunswick in creating NSWOCC SWAN teams. So if you have a chance, I know Mandy's here. I think Matthew is coming in by Zoom. But ask them what they're doing. It's extremely creative, and it is setting the way. And we talked about it at Swan Night the other night. And then I wanted to thank all of our sponsors. It always goes without saying, we cannot put these meetings on without our corporate support and our sponsors. They're here. I see some of them in the room, at the back of the room, Jeff Vorney and Kevin and others. So please go to the booths. It's very, very important to take the time to meet with them. And I'll turn it back now to Denise.
We have, so everyone has in their folders today's agenda. So follow that. That kind of gives you an outline for the day. There is one change. Erin Rushton is going to be presenting at 9:45, and Marcy will be taking her place in the afternoon. Thank you, Marcy, for switching up. An impressive lineup of speakers, and we want to thank you guys all for volunteering to speak for us today and educate us about best practices. I'll tell you a little bit about each of them as they come up. Yeah, as Kathy said, be sure to network and with each other, and then go see the vendors as well. So we do have several volunteers, and I don't know where they all are, but we all have an NSWOCC related, NSWOCC Canada related shirt. Joan and I have the blue, linked to kind of the Indigenous Core program, and then we'll see the black NSWOCC. And I don't think we have a SWAN one, because I was thinking Priscilla's here, but, and anyway, so please come to us if you have any questions or anything like that, and then we can direct you where to go. Oh, there's Nancy. Nancy's volunteer in the front, and we have Sylvie and Natalie and Mandy and Joan. Am I missing anybody else that volunteered? Oh, Melanie, sorry, Melanie and Kathy and I. So just reach out to us if you need anything. Okay. I have a bag full of NSWOCC shirts that I brought, and I even brought my house coat, but I won't pull that out till later maybe, but Food is going to be, if you walk straight ahead, it's going to be in the same room where the vendors are. So you pass the front desk, you go straight and then turn to the right, like Kathy said. So food will be in there, and coffee this morning for break and things like that, for anybody's needing their coffee. Restrooms are straight ahead as well. If you walk literally straight ahead past the front desk, there's bathrooms there, and then you'll turn right and be able to go into where the vendors are. And then I think that's it. We're ready to start the day. We have Joan and Sylvie. Are you guys coming up? Yeah. And so, yeah, we're ready to start the day. So next up, we have Nancy Schuttenbelt that I've known probably 30 years now, because when I was an LPN and I started at Chalmers Hospital. So she's an NSWOCC, has lots of experience and works in the Fredericton area currently, and has really been doing a lot privately with government funding and all that kind of stuff. So she's definitely a trailblazer in the NSWOCC world, and has a big passion for pressure injuries, and currently actually on the CPI AP board, the Canadian Pressure Injury Advisory Panel. So yeah, she's going to talk to you about pressure injuries and skin tears. So thank you very, very much.
So what I'm going to be talking about is primarily pressure injuries and skin tears, and just a quick review of what's been going on, what we've been doing, and where we're going. So over the next half an hour, we're going to talk about skin changes as we age. And why am I focusing on this? Is because our population in New Brunswick and Canada, we are aging. And that's a big portion of our population. We're going to look at the early signs of skin breakdowns, talk about risk factors, causes, why pressure ulcers are still happening with injuries with all of our education, looking at skin tears, and hopefully increase our knowledge a little bit on some prevention strategies. So skin changes as we age. The skin is the largest organ in the body. It contributes 12 to 15% of total body weight. By the age of 70, the average person will have lost about 105 pounds of skin. Dermal changes with age include reduction in the thickness, elastic fiber, changes in the dermal ground substance, decreased vascularity, density. The blood vessels of the dermis become more fragile. This leads to the bruising, bleeding under the skin, and that's where you get that senile purpura or cherry angiomas, and you can see a picture of it there. And with aging, the outer layer of the skin, the epidermis thins, even though the number of the layers remains unchanged. The changes in the connective tissue reduces our elasticity and strength, more noticeable in sun-exposed areas. And then we get that weather-beaten appearance common with those who spend a lot of time in the sun. And if you look at those pictures there, and even if I look at my own hand in my 50s, I see the changes in my skin. I find my skin is drier, despite my 2 to 3 liters of water a day, etc. So those are things that we can't control to a certain degree. Okay. So the number of pigment-containing cells of melanocytes decreases, the remaining increase in size. So that aging skin looks thinner, paler, clear, translucent. Those pigmented spots are liver spots, right? And the medical term is lentigos. And we see that probably every day. If you look at the picture on the right of that person's back, I'm not sure how good that's, oh yeah, that's coming in. I should have brought it closer. That's a patient of mine that I see in my private practice. And he had on his back, when I first met him, like the normal aging skin tags. And he and his wife have been in Arizona every year for 20 years. And now, unfortunately, he has Lewy body dementia, and he has 24-hour care at home, and just a beautiful family. But when I met him, his skin was really red and raw, and it certainly didn't look like that. I should have done a before and after picture. And what it was in his case is his caregivers, the urine, he's incontinent at this point. They were failing to, when they changed him, if he was really wet, to do all the skin in the back. And he ended up with urine burns on his back to the point where he looked like it was like a moisture-associated dermatitis. And it was simply a matter of changing that pad more often, turning him every 2 hours and getting him up. The family is very fortunate. They have the financial means. There was a Hoyer lift in the house and everything for this man. And I asked when he had last been up in his wheelchair, and it was 2 months ago. So he was in bed for 2 months. So his back is beautiful there because they just changed their practice. And it was just a matter of me teaching them how to use the Hoyer lift, getting him up out of bed every day. And that's the criteria now for this beautiful family. And his back has cleared. So now what it's left, now that that incontinence-associated dermatitis has healed, his back looks like a normal 84-year-old's back with the skin effects from his great years in Arizona and the aging of skin. Okay, so true or false? In general, age-related skin changes begin during the 6th decade of life. What do you think, true or false? It's actually true. But remember, by the time we hit 70, we've lost 105 pounds. So kudos. So dry skin is especially common in the elderly, and I haven't even hit my 60s, and I see the changes in my skin already. So the greater the severity of the dry skin, the higher the probability of having a pressure injury, and that's how this all correlates. So having severely dry skin was associated with almost 3 times greater odds of having a stage 2 or greater pressure injury. And that was a study published by Valser in 2024. You can see by my age, I need reader glasses too. Okay, so we can see the skin tags and the warts. Those brown rough patches, seborrheic keratosis, I'm probably pronouncing that wrong. And that's a common non-cancerous skin growth that can appear in middle age and becomes more frequent with age. They're not precancerous, but can resemble other skin growths that are. These growths are raised or waxy, scaly, and they can look like mold, or they look like stuck candle wax. They're not contagious and they don't spread. And they usually treat them with freezing if they're bothersome. But what tends to bother people in their senior years is the appearance of them. Oh, they look so ugly, they'll say. I'll hear that frequently. And then the other kind, the pinkish red patches, that's the actinic keratosis, and they're sometimes called solar keratosis or senile keratosis. I don't like that name. And that is a precancerous area of thick, scaly, crusty skin, and often occurs from tanning, damage from a lifelong of sun exposure. It's more common in the face, the hands, the scalp, and again, the treatment is often freezing, and you would have them assessed if you're concerned. Okay, so this is a friend of mine that I see in the community. I see him for ostomy care and skin care and checks. This is his lower legs. What do you see when you look at this picture? Super dry skin, huh? And he puts cream on it twice a day. Yeah, and we see 2 wounds. Yeah, and they are related. They're not pressure injuries. You can see the location, their lower leg, but they're from circulation. So do you see any skin tears or pressure injuries on this picture? Nope. But in actual fact, and his name is George, and he doesn't mind me sharing because I'm always taking pictures of him. I just love him. And he actually has a skin tear on his lower arm, and he had a pressure injury beside his, he has an ileostomy that he's had for like decades and decades. And how did he get the skin tear on his arm? First of all, because of his age, he's in his 80s. I'm 89, Nancy. I'm going to be 90 soon, he tells me. And what happened was when he was still in hospital, now he's in Shannocks, and getting amazing care, by the way, if anyone's here from Shannocks and Fredericton, his skin has never looked better. I was so impressed. I was so proud. But when he was still in hospital, one of the care workers had a sweater on with a button. And just that, I guess I don't have a button on mine. And that button, when she was transferring him up, just rubbed against his skin. And because he has that tissue paper skin, boom, great big skin tear. It was just like, unbelievable. Anyways, that has healed up. And he will get off and on through the years the odd pressure ulcer around his stoma from pressure, if the pants were too tight or something. But again, frail elder, right? So early signs of skin breakdown, we're looking for skin that feels softer. We have those boggy heels. Blisters are later. For dark-skinned individuals, and I'm going to share some pictures in a few minutes that Melanie provided. Thank you, Melanie. You're looking, it's darker, more warm. So in your skin assessment, you're going to look at moist skin, think about your skin microclimate. So we now recognize how the microclimate and processes located in the epidermal and dermal layers of the skin can predispose us to the development of pressure ulcers. They both increase and decreases in skin moisture can affect the friction and affects our tissues. Okay. In that picture there, this is another lady I see in the community. If you see her shoes, you see her sandals that she wears 10 months of the year. They're Clark's, by the way. She'll tell you that there's no other shoes than Clark's to wear. But if you look at her foot there, that baby toe, and I'm not sure if I captured in the picture or not, it's quite red along the side and it's a little bit swollen. And if you look at her shoe and where the pressure is on the shoe, chances are it's from rubbing on those shoes. And it was extremely, extremely painful. So what would we do? We would offload the area, get different shoes, right? And she has these two amazing sons that live out west, and they're like, oh, we ordered these shoes, these new shoes. They sent her two beautiful pairs of shoes. And she says, nope, I like my Clarks. So those shoes sit in the box. Anyways, and so we just adjusted her shoe. It has a Velcro, you can see, and still painful. Well, of course, it's going to be painful because we haven't been able to offload that pressure. So I ended up choosing a foam dressing that had some ibuprofen in it because she was having a lot of pain from that. Okay, so early signs of skin breakdown, the redness discoloration that doesn't fade when the pressure is relieved, changes in the skin textures, and areas that feel warmer or cooler than the surrounding skin. So let's talk a little bit more about that skin microclimate and how it affects our skin health. That weakened skin, that excessive moisture or maceration makes the skin weaker, more fragile, reducing its tolerance to that friction and shearing. Increased sensitivities, the higher skin temperatures can increase the skin sensitivity. And then you can lead to friction shear, the maceration that we see. And the high humidity leads to moisture buildup on the skin surface, causing it to become soft, breaking down, and then we get that maceration. And it's funny when we talk about temperatures, like, who hasn't been in a room that it's like 100 degrees and that elderly patient says, I'm cold, can you turn on the heat? And that all has to do with the aging process in our skin. I know my mom in her last year or so was in assisted living, and we visited her every day, and she would say we'd come into the room, it would be January -20 outside, her room would be 35 degrees. And we would start taking the layers down, and she'd say, oh, Nancy, I'm cold. But we know, again, aging, right? So pressure ulcers or pressure sores can begin to form in as short a time as 2 hours. True or false? True. Pressure injuries can begin to form in as short a time as 2 hours, and they can be serious. They can lead to infection, as we know, if left untreated. So the definition of pressure injuries, we all know that. And the injury can present as intact skin or an open area. It might be painful. More than 700 new articles were added to the pressure injury literature in 2023. And that's challenging us as clinician educators and researchers who are trying to stay current. In this article where they combined the 700, they brought it down to 6 articles and provided important new data or insights about pressure ulcers. And they talk a lot more now about the microclimate and the processes located in the epidermal and dermal layers of the skin. And they talk about the effects of the moisture and the friction and shearing and the deeper tissue injuries.
What happened to mom? She went in for a broken hip and her hip, even with diabetes and everything. No, really hit. He feels that really good. And she ended up in the dentist. People different reasons, about the meetings from the politics and the conversation. We didn't know all that is this. But when the advantage of this here, it was, it's just, for people. Like today, we all cried, but it was so bad. And we're sitting in the home. Nobody wants to see it because this, nobody had ever seen it.
The often, but still depending on the health condition of the difficulty of the skin. For you, in all these different hospitals.
So as we know, we've seen pressure injuries in every facility and how they develop. What strikes me about that is, did she fall into that category of unpreventable? Could we have prevented it? She was at high risk from everything that we've talked about so far. And obviously immobility, declining health, et cetera. But what strikes me about that video that always gets to my heart is the communication. And just a reminder to us to make sure when we have someone at risk and starting to break down that we let that family know right away what's happening and what we're doing and high alert. It was shortly after that came out, because that was all over the CBC. That was many years ago, but I always tend to include it in my presentation. It gets to me. She has died since that time, by the way, about 8 months later, since that video was taken. But it's the communication, and I wonder if we had communicated to the family better what was going on and how high risk, could we have changed her course of her health? Shortly after that, I had a lady come in to the deck with a great big black area on her bottom. She had been at home living in her own apartment. She was in her 80s, a strong German lady who loved to smoke and drink coffee. And her son had wanted to buy her a Lifeline. And she said, absolutely not. And she was a diabetic. She fell at night and no one found her for a couple of days. So she came into the hospital, big black area on her bottom. And the first thing I did when he showed up and we were in to assess it, I said, do you know what this is? This is very serious. And I really tried to educate him about what we would be in for. Eventually she healed, but it was like 10 months later, we ended up, she went to the OR, debridement, vac, et cetera, or vacuum assisted closure, et cetera, et cetera. But the importance of communicating to all, not only us, the team, to the family. So this is a lady who developed this on her heel under my care and the care of the unit I was working on at the time. And frail elder, did not eat. We thought we were turning and positioning her enough. We had a heels up to float those heels, and she still developed this one day. So how could we have done better to prevent this? Obviously, we weren't healing that up enough and turning and positioning her enough. So sometimes they can be really tricky, especially for those that are high risk. So how to prevent the pressure injuries, we know all about it. Assessing our skin. Does the skin blanch? Is the area being offloaded? Check those pads frequently. They talk about the CBPM available at some sites, and that's the continuous bedside pressure mapping. And I don't think we have it. Do we have it anywhere in New Brunswick? 10 minutes, thank you. Or Nova Scotia, is anybody using that? Okay. So are the heels floated off the bed? We've got all kinds of pressure injury prevention programs. We've got prompts that remind nurses of the need to position, and one would think that continuous bedside pressure mapping, which identifies the areas of the body that has been exposed to prolonged pressure and alerts when positioning has not occurred, would be beneficial. But the data today so far isn't really convincing. And in an article published by Ho et al. In 2023, they explored the efficacy of the CBPM. And they found that, the efficacy wasn't great. The data wasn't very convincing at this time, but who knows in the future. So true or false, topical antiseptic should be used for pressure injuries that are not expected to heal and are critically colonized. True or false? Do you think? It's actually true to reduce the bacteria burden and decrease your inflammation. So staging of pressure injuries, we have cards, I believe, at every site, from home care, from our extramural programs to our in-hospital sites. And stage 1, it's just when we push our skin and it does not blanch. That's a stage 1. Stage 2, the skin is broken into the epidermis and dermis. Stage 3, that pressure injury extends further into the subcutaneous fat layer. And stage 4, undermining is likely, and the ulcer extends to muscle and bone. And those are some pictures, thank you, Melanie, of darker skin tones with pressure injuries. So interventions, we know all about these. We try to implement them into care. We know how dry skin is so common in our elderly population. And in a study published in 2025 by Volter et al., they implemented a structured skin care and prevention program in a realistic study. They used a control group. It was a 2-year study. And the results concluded that a comprehensive skincare program can successfully be implemented and offers benefits for the prevention of pressure injuries, skin tears, and in the skin fold dermatitis. They ended up with lower pressure injury rates from 13% versus the 17% in the control group. And the study also found that 95% of the participants had a really dry skin. So I just wanted to include this slide. This is the Canadian Pressure Injury Advisory Panel, and Cassie has done a tremendous amount of work on that. Troy, and there's representatives from all across Canada, is up and running. It has excellent resources for everyone, and as it continues to be developed. So please check it out. And they're going to be adding a section this fall, and it's called Pressure Points. I thought that was so cool. And it has each of the provinces listed, and then you click on the province, and it will give you your pressure injury policy from that province, and that, so that we share our resources across Canada. And Shannon Hanfield has done a lot of work on that, along with Troy. So was this a pressure injury? What do you think? Yes or no? Above it, yeah, right above by the tailbone, isn't it? Below that, we've got, that's actually moisture-associated skin damage, and that is from just prolonged exposure to urine. What about AI in staging of pressure injuries? We know that for years we've had all kinds of programs for teaching our teams how to stage pressure injuries. We've got the cards, we've got the e-learning modules, but we still struggle when we see a pressure injury. Has it been staged and documented? So a study published in 2023 in the Journal of Advanced Nursing, they concluded that their AI approach to staging pressure injuries performed comparably to experienced nurses and maybe benefit for less experienced nurses staging pressure injuries. So we'll see in time. Skin care and moisturizing. We know that the skin barrier creams protect the skin against moisture damage and moisture loss, and the moisturizers, of course, add moisture. In what percentage of patients has pressure injuries has osteomyelitis been found? A, B, C, or D? Actually, D, up to 32%. Skin tears. We're going to quickly hit skin tears, 5 minutes left. So the International Skin Tear Advisory Panel has a skin tear classification system. Type 1 is a no skin loss. That's a flap that can be repositioned. Type 2 is the partial skin loss. And 3, you can see that the whole area of skin has been taken off. So when treating the skin tears, the first step, of course, is to control that bleeding, cleanse the wound, and reapproximate the wound. And oftentimes we've had good luck with skin glue. They've stopped suturing in most facilities, and for obvious reason. When you think about that tissue paper skin, what happens when you suture it? It falls apart, right? So, so if the edges are approximated and there's not a lot of bleeding, the skin glue works well. Non-stick dressings, foam dressings, silver dressings, and more. There's a best practice recommendation for the prevention and management of skin tears, and that was from Dr. Kim LeBlanc, and it's got great resources in it. So that was quicker than I thought. Our take-home message is structured skincare programs might help prevent pressure injuries. The benefits of the CBPM remain uncertain. It's important to minimize delays in providing pressure-reducing equipment to home care patients as well as inpatients. I forgot to talk about that study. They did find that when you put a surface in the home care setting from hospital to home care for those at risk, because we're not going to change the fact that they're 92 and still at high risk, that it does decrease the incidence of pressure injuries. Minimize delays in providing the equipment to the home care patients. AI may have future implications in staging pressure injuries. It's pretty early. And there's best practice recommendations for the prevention and management of skin tears that are used widely and effectively. And within there's those great little reference sheets. And they have that for pressure injuries as well. So spread the word and practice good skin care and prevention. And who says nursing is stressful? I'm 39. I feel great. So that's it.
Thank you so much, Nancy. I have a little gift for you. I'll run it to, or do you want to come get it? Thank you. Kathy may have just showed me some pictures that are on NSWOCC Canada, if anybody wants to check out there. But anyways, we're sharing about the day, but I want to thank you. Is there any questions? Does anybody have any questions in the room?
I have a question online. For an intact pressure injury like a stage 1 and deep tissue pressure injury should be cleansed with antiseptics. Could that dry the skin more, making it more likely to break down?
You can. I think we always get wrapped up in what product should we use, what should we do. The bottom line is keep the skin clean and dry, moisturize if it's appropriate, and put on like a protective layer if it's necessary. Things like a hydrocolloid or a film, can help prevent.
Yeah.
And it all
And-
depends patient.
Well, and I often find, especially with deep tissue pressure injuries, like they're the purple discoloration, and they are devastating because I've had some people refer to them as being superficial wounds. And so that's kind of hard to hear because we know that they will evolve, right, to something more. So it's kind of a watching and waiting. So sometimes we'll put even some Adaptic and then some of our foam dressings and offloading, and then we wait, right? And hopefully it'll lighten and go away. Or if not, it'll evolve to something more, right? And then we need to get into more wound care. Okay, so I'm going to hopefully figure out how to get out of here. Our next presentation, we had our little change in our agenda, and it's Erin Rushton is coming in now. And we are very happy to have her here today with us. I've known Erin for a long time as well. And she's been a big advocate in the NSWOCC world, and we've been really happy in the last couple of years. You've been in NSWOCC as long as I have, 2016. In the last couple of years, she's been advocating for years to have a position in Amherst Hospital, and so now there is one, and she's the NSWOCC there, so we're so happy. And she's also a fellow ostomy camp nurse with me, so we've been bunk beds together. Well, she got the bottom. I had to go on the top that year. It was terrible. Everybody knows about it. The rungs are tiny and they're hard on the feet anyways. But yeah, so Erin is up next. And does that look okay? That's good, Troy? Yeah,
Yep,
good.
looks
Okay, come on
great.
up, Aaron. Okay, it's all you.
Oh, Denise. I'm very short, so I'm sorry. Um, I actually, this is not my presentation. It's Carrie Colson's. She is an NSWOC, but she is also a continence nurse initially. And she couldn't be here today because she's on a cruise in the Mediterranean. So I don't feel sorry for her. But yes, they asked me to come and present, and these are Carrie's slides. And I apologize if I have to stop and take a little coughing break because I'm not feeling the best today. So whoever switched so I could come this morning, thank you. So prevention padding and protection management of urinary incontinence. And I think I just pressed the button. Yay. So is incontinence an expected outcome of aging? Yes. Correct. Okay. So factors that can contribute to incontinence in the elderly. So we have age-related changes in the bladder. So the bladder does change as we age, but that does not mean we are incontinent. Decline in mental status, decreased mobility, limited dexterity, medications, prostate enlargement, postmenopausal vaginal atrophy, undiagnosed urinary tract infection, and dietary habits. Oh. And some facts about incontinence. So approximately 24% of Canadian adults are living with urinary incontinence, and this costs the Canadian healthcare system $3.8 billion. So urinary incontinence is the involuntary leakage of urine at the wrong time or the wrong place. And this is what the patient perceives as the wrong time and place. And how much urine is irrelevant. If it bothers the individual, it should bother us. And we're going to work with the patient and client to help them improve it. We never downplay incontinence as normal. I have a background in primary care as well. And I do a lot of patient intake interviews. And when I ask people about incontinence, I get no more than normal, and I'm like, no, none of it is normal. So let's talk about it. Incontinence should be the goal for every client, and incontinence should never be encouraged. So psychosocial impact, and these are tiny. So decreased quality of life, impaired self-image, anxiety, depression, social, I can't see that if anyone else can. Thank you. I know. It's very hard to read someone else's slides because you have to get into their mind frame about what they wanted to talk about. Shame, loss of independence, and increased risk of being placed into care, and security, sexuality and intimacy, and disrupted sleep, and limited ability to participate in religious ceremonies. Oh my God, there's more. And feeling unhygienic. I'm sorry. And stigmatized. Those are the smallest ones, I promise. Okay, the physical impacts or the associated skin breakdown can be very painful, increased injury or risk for developing pressure injuries, and I'm glad Nancy was talking about that. Increased risk of skin infection and risk of falls. So we talked about the 3.8 billion, but what we didn't talk about is the individuals. So individually, it could be $1,400, $2,000 annually. And if you're of an older generation and on a fixed income, this is a lot of money that you may not have available for. Yes, thank you. Thank you. So yeah, they don't have the money to spend on these incontinence products. And can urinary incontinence be cured? Not always, but can it be improved? There. So management versus curing. So we're not always able to cure it, but we can help improve it to a point that hopefully improves the patient's quality of life. It's very treatable, and there are many treatments available, but as it says down bottom there, 70% can be improved by just behavior changes. It depends on if the patient is willing to make those behavior changes. Now, the types of urinary incontinence. So in primary care, one of the things I said to people was, if you laugh, cough, sneeze, or lift something heavy, will you pee? And about half the time, and I'd say in ladies over 55-ish, they'd be nodding before I even finished the sentence because they knew where I was going with it. And then I would say, if you were driving from A to B, and it would usually be a 20-minute journey, if you get halfway there and you have to pee, can you hold it? And that would tell me if they were incontinent and what type of incontinence they had, and that would kind of lead in further from there. So the stress urinary incontinence is the laughing, coughing, sneezing, lifting, and that's weakened pelvic floor muscles that result in less urethra resistance, allowing urine to escape through the sphincter. And conservative management would be your pelvic floor exercises, which are the Kegels. We'll talk about those a bit later. Timed voiding, pessary, which I did not know this, but is often described as the underwire bra for the urethra, as it supports the sagging bladder neck as the underwire supports the breasts, and vaginal estrogen. Oh, I think I skipped one there. Nope. And urge incontinence is the incontinence caused by the inability to hold the urine once the sensation to void occurs. And it's usually, not always, a very large, their bladder will just empty. And associate it with inappropriate bladder contractions during the storage phase of urination, and can be related to weak pelvic floor. So there can be bladder abnormalities like infection, stones, tumors, painful bladder syndrome, and some medications can cause or exacerbate it, like diuretics, antihistamines, antipsychotics, antidepressants, narcotics, sedatives. And I was just informed by a pharmacist that some stimulants, because a lot of people are getting diagnosed now with later stage ADHD, and they're being put on stimulants, and they're noticing they're having trouble now with their urine. Age-related changes in the bladder capacity. Nicotine can increase the frequency and strength of bladder contractions, and alcohol and caffeine can impair bladder function. And so for treatment is limiting these bladder irritants. Pelvic floor exercises can benefit, but bladder retraining is often the most beneficial treatment for them. I'm not going through these medications, but these are some of the medications that we can help to treat. Unless you have the nurse to prescribe course, I don't think, unless you're a doctor or a nurse practitioner, can prescribe any of these. And sometimes people have mixed, which is great. So you have to treat, because there are different ways to treat them. Treat the one that bothers the patient the most. So if the whole bladder emptying as soon as they get the urge is what bothers them, treat that first. Whatever you can do to help in their quality of life from their perspective is what we go for treatment. So functional incontinence, this is just where a lot of time they can't get to the toilet in time. So a loss of urine caused by factors outside of the urinary system, which interfere with the patient's ability to respond in socially appropriate ways to the urge to urinate. To maintain continence, there must be an intact sensory and motor function, as well as the ability and desire to respond to the urge. So things we can do. So mobilize your patient as much as possible. Provide bedside commode, urinal, or bedpan. Dress the patient in clothing that's easy to remove, and clearly identify the bathroom, and use raised toilet seats. Denise, stop. No, I was telling you to stop giggling. So,
I think she's arriving home.
yes, Carrie is arriving home this morning, or she's already home. So provide privacy, avoid the diaper style incontinence products, because they promote the perception of incontinence. I just had a patient this week. I was in for venous leg ulcers, and we started talking about a rash in her groin, and what are you wearing for underwear? Oh, I'm in a diaper, were her words. And I said, do you wear that at home? Oh, no. And I said, why are you wearing one here? She didn't need it. It was for her own peace of mind, because when she was ringing the bell, the nurses may not be able to get there quick enough. So I strongly encouraged her to just, let's get your underwear and we'll put a pad inside your underwear, because then you can pull them up and down. But she was very scared that she was going to be incontinent. So this is what her choice was. Toilet regularly, so the prompt at voiding, and whenever possible, avoid medications that impair the cognition sensation, such as sedatives, hypnotics, and narcotics. So what you wear matters when you're living with urinary incontinence. So Harold, what do we need to change about Harold? I can kind of hear everybody talking here. So sturdy non-slip footwear, properly fitted mobility aids. So the way he's standing, that cane probably isn't gonna cut it. No belts, no braces, no zippers, buttons, or clasps. Untuck his shirt. No long johns or one-piece underwear. I used to have people come for their B12 shots every month in a one-piece long john, a flannel shirt, and braces. And I'm like, you know you're coming and you have to show me that arm. And he did it every time. They're hard to change. And elastic waist pants help a lot. So interventions to help prevent from occurring as frequently as it does. So pelvic floor exercises, and I fight with ladies on this all the time. You don't get abs in 2 weeks of doing sit-ups. You're not going to fix your pelvic floor muscles in 2 weeks of doing Kegels. You have to stick with it. You have to do the exercises consistently, and you will eventually see a difference. But you just have to stick with it. It doesn't happen overnight. It's a muscle that you have to build. And they are 3 to 5 times a day, one set of 10 contractions held for 3 seconds each, and then you increase that to 5 as you're able to hold them. And the patient must be able to understand what you're saying. So someone with dementia who's going to forget what you're saying, 5 minutes down the road, the Kegels are not going to be what helps them. And they have to be taught, when I ask people to do them, if I see them, if they lift, they're using the wrong muscles. They're using their bum. And so you got to try and figure out and help them to isolate the correct muscles. And you can do that through an EMG biofeedback or a digit inserted into the vagina or rectum. And pelvic floor physiotherapy is also another option. And a bladder diary. So it's inexpensive, just a piece of paper, and you send them home with something to measure with. It's good information on the frequency, urgency, incontinence, and fluid intake. You can do 3 or 7 days, and usually it's quite surprising. I've had to do one myself, and I thought I drank a lot more water than I did, and I peed a lot more than I did, and that was a lie. And I got in trouble for it. So it actually, a lot of people over or underestimate what is actually going on. Prevent constipation. So this can increase urinary retention in a patient experiencing BPH or pelvic organ prolapse. The straining of constipation can weaken the pelvic floor, and abdominal and pelvic pressure from the buildup of stool can make you lose the sense of the urge that you have to go to void. Nutritional assessment is provide adequate hydration to avoid constipation and or concentrated urine, which can contribute to urinary and fecal incontinence. And one that I always hear Carrie say, because a lot of people will try to limit their fluid intake before bedtime because they don't want to get up through the night and have to go. She will say, if I had a bucket of bleach, would you put your hand in it? No, it's going to irritate and burn your skin. If I diluted that bleach, would you put your hand in? Yes, because it's not going to irritate and burn your skin. The same is true of urine. The more concentrated, the more it will irritate the lining of your bladder and kind of increase the contractions and the feeling that you need to void. So I always told people, please don't limit your fluid before bed to the point where your urine's going to get concentrated, because they're still having to get up because they still feel like they have to pee because the urine is irritating everything. And avoid bladder irritants such as caffeine, alcohol, acidic, and spicy foods. So mobility and dexterity assessment interventions. So these are for the people who just can't get there. So PT, OT, a clear path to the bathroom free of clutter, and rugs. I don't know how many people have those rugs with the corner that curls up and they'll trip. Adequate lighting, dressing properly. Call bell within reach and answered promptly. And I know this happens. I have been part of these patients before. Something's going on in the unit, they ring, they have to go to the bathroom, and that is your lowest priority because someone down this end is coding. So it happens. try to get to them when you can. And whenever possible, bedside commode instead of incontinence briefs or a bedpan, and use a high toilet seat or commode. Cognitive assessment. So prompted voiding. You guys worked in the nursing home. Did I see you guys raise your hands? Or Shanix or something? Yeah. On the dementia patients, do you still do the prompted voiding? Like you take them, anyone here in a nursing home, you still take your dementia patients to the bathroom every 2 hours or yeah. Because even though their pad may be wet, if you sit them on the toilet, most times just sitting on the toilet, they will pee for you. It's just, they have to be reminded and sometimes physically put on the toilet to pee. Label bathrooms clearly as just toilet. Promote independence. Do not encourage the patient, like it's okay, go in the pad. No, please change them or take them to the bathroom rather. And as much privacy as we can, and promote social interaction to avoid isolation and depression, which can lead to the incontinence. So medications, so we talked about medications that can lead to it and ones that can help it. But we should get a pharmacy or a pharmacist rather to review their medications because there may be something we're not thinking of that is contributing to their incontinence. And sometimes no matter what we do, we have to consult urology because if we have an overactive bladder and large prostate, nothing else we're doing is helping. They may actually need to go on to something else. I see you with your little water there, Denise. Thank you. Don't drink out of it because I'm sick. Okay, if urinary or fecal incontinence does occur, we need a skin plan. So what is, and Nancy kind of touched on this a bit with that little patient, IAD. So incontinence-associated dermatitis is an irritant contact dermatitis associated with exposure of the skin to urine and or stool. I say diaper rash to patients because that's what a lot of them know. And it is a part of a broader group of skin conditions known as moisture-associated skin damage. So I'm going to try and break this down. So your healthy skin is acidic. When it's exposed to urine, it becomes more alkaline because skin bacteria will convert the urea to ammonia. So the increase in the pH allows the microorganisms to thrive and increase the risk of skin infection. If they are also incontinent of stool, especially if it's liquid, this can make it even worse. So liquid stool contains more moisture and digestive enzymes, which increase the risk of skin breakdown. And it can also act on the urea to produce ammonia, which further increases the pH. So when a patient is incontinent of both the stool and urine, it is a much higher risk of skin breakdown than if either occurs alone. So the healthcare costs, IAD increases the amount of nursing time and costs necessary to manage the care of the incontinent individual. And if a pressure injury occurs as a result, the increased cost can be incremental. So a stage 2 hospital-acquired pressure injury to treat can cost around $44,000. And that can be just because we didn't treat the patient with incontinence appropriately. So, best practice guidelines. Should you provide skin and incontinence care to the elderly using bar soap and body wash? Yes. And I heard someone say balanced pH too. So cleanse, protect, and restore. So a lot of products are available with 2 or 3 functions. So I know there's a wipe out there that goes in a little heater and it has the moisturizer and the barrier wipe and all that kind of stuff in it. You want products without dyes, fragrances or preservatives. I know right now I'm fighting to get out of my hospital. It's a bottle about this big. It's green, smells like, I don't know, apples or pears or something. Not pH balance appropriate. You do have to rinse it. And the first question I got was, well, what will we wash our patients with? And I'm like, the other cleansers we have here that are pH balanced, please. So the managers are trying to help. And just if it's best practice, we're going to get rid of. Does that mean you have a question? Oh, like, what does that mean? I missed the first of it. I'm sorry. I have 10 minutes apparently. So Some studies support single-step all-in-one products, like I was just talking about, and having a structured skincare regime that incorporates gentle cleansing and skin protectants. So please pat, don't rub. I see some people just giving her, and I'm like, please don't do that. Apply barrier cream with each episode of incontinence if there's any redness or skin breakdown. Use underpads while in bed instead of diapers if possible. There's lots of times I'll see an incontinence pad, a soaker, a lift pad, and then the bed linen all on top of the bed. And I'm like, do you know how hot and sweaty that is for that person? And use pads in their undergarments instead of their diapers. So avoid traditional soaps because the pH is off. I've done a presentation years ago now for some CCAs who are coming into the hospital and they need it, like we were talking about, just skin cleansers and stuff. And I went down the rabbit hole to find the pH of the soaps that were on the market at the time. And none of the soaps out there, well, most of them, I won't say none, are pH balanced for our skin. They're just not made to use every day on our skin as healthy skin. So skin that is already to break down, it's not good. So we have to really look at the pH and make sure it's non-rinse. Use a soft cloth, avoid aggressive drying or rubbing, and check the patient frequently for incontinence. So protect. So when we are prescribed a cream for that fungal infection, I always say put the cream on and then wait half an hour roughly before you put on the barrier cream, because I always get, well, what do I put on first? How long can I use them both? That kind of question. Yes, you can use them both. We just have to separate them a bit and give the first one time to work. There's liquid barrier film, zinc oxide, petrolatum, I don't know why, but I like that word, or dimethicone, should be used with each cleansing. If they are incontinent, you just have to wipe off that top layer. Everyone wants to scrub down to the skin. Just take off the stuff that is dirty and then add more. Make sure the patient doesn't have any allergies to zinc. And liquid spray barriers may be needed if the skin is extremely excoriated. And that would be like your barrier wipes. And when possible, barrier products that are transparent and easily removed so you can actually inspect the skin, and avoid application of, I've seen people do the great big thick globs of the zinc and then they put a pad on, and that interferes with how well the pad will absorb any incontinence. And restore moisturizers. So, and Nancy had talked about this too. So ointments are too greasy and tend to be too occlusive in this area. Creams are a better choice. Avoid getting cream in the skin folds to prevent trapping moisture and causing maceration because it's usually already wet down there. And apply cream by gently putting it on and try not to rub too hard to increase friction. And so external collection devices. Does anyone use these, like the female catheter? Do you know what I mean? What is it? Yeah, the PureWick. Do you guys use them? Oh. Oh. Does anyone use them? No? I hear someone talking, but I don't know where you are. There you are. Yes. You don't use them a lot. Okay. Is it because people don't like them or they don't work? Both. Okay. Fair enough. So which incontinence product should you use? So whatever the patient finds easiest to use, and you're gonna kind of like this elderly lady I was talking about earlier. I don't think she needed the diaper. I think she would have done fine in mesh underwear and a pad, but that's what she preferred, so that's what we went with. Is important to remember, incontinence product is not a replacement for toileting. They should be changed before reaching their capacity, and your decisions should consider the goals of restoring continence and extend the type of incontinence, mobility levels, and skin health. If the patient is mobile and has occasional or light to moderate incontinence, I'm so sorry, guys. I took something to dry up the mucus and I think it's drying everything up. Yeah, or the mesh underwear, and mobile patients with frequent or moderate high volume incontinence should wear pull-up styles to promote independence. They can still go to the bathroom and pull these down. I find when they have the diapers on, I know what that 5 means now. They can still pull them, but when they have the diapers on, they can't really undo them and get to the bathroom themselves. They find it quite a bit harder. And only patients who are immobile and have significant urinary incontinence should wear a diaper style product. And even then, if we can, we should leave it open so that it's not so occlusive. So remember, wearing an incontinence product makes a microclimate, and this increases the skin temperature, which increases the humidity, and the skin the skin's ability to lose moisture through evaporation, and overhydration results in skin disruption. And it also promotes microbial growth. So never double pad. Does anyone here do that? I will give you dirty looks. No? Okay. Sorry? Yes, don't admit it, but stop doing it, Denise says. I will say about, I don't know, 20 years ago when I worked in a restorative care unit, we did it, but it was so usually on a dementia patient in the middle of the night. So we could go in at 2 o'clock and take out the inner pad, close it back up so they wouldn't wake up. I will admit we did that. That was 20 years ago. I'm hoping they don't still do that unit. So the back of the pads are waterproof. So fluid doesn't flow from one pad to the other. If you're hoping that someone is so incontinent, you're going to double pad them to catch more. The extra pad interferes with the wetness indicator, so you can't actually see when they're full. And it's very hot wearing 2 plastic pads on for incontinence. So you're increasing the microclimate. So try to choose something more absorbent. I know some people are just very, very wet. So, and managing your cutaneous candida. So apply generously, but not to the point of being visible. I said half an hour. She says 15 to 20, but I wait half an hour. Continue even after it has gone away, because I find a lot of people will say, oh, the bumps are gone. They stop. And then 3 days later, oh, they're back. Please keep using it. It's like an antibiotic. Keep using it. And if the response to a topical antifungal drug is poor, they may need an oral antifungal. I got it in the 5 minutes. There we go. So thank you. Harry said to tell anyone if there's any questions, feel free to give her an email, because if I can't answer them. So if there's any questions, please email Carrie. Unless you have something now and the other NSWOCCs can help.
Well, we have a question. I'm coming over. Just hold on.
This is just out of curiosity. I work in a nursing home and I'm not sure if it has to do with the catheters themselves. But we're running into more issues with catheters and them bypassing. And it's not just with one resident, it's with several, because I figure, well, if it's one, then maybe it's just that resident. It's becoming an issue because we do feel pressure from not only families or CCAs to change them, but the more often we change them, we all know what's going to happen. I'm just wondering what would be the intervention rather than changing it frequently. I'm assuming a lot of it has to do with the presentation of like medications, or if there's other things underlying going on, but I'm just wondering, like, intervention wise.
Sometimes they get airlocked. I assume you guys are kind of checking for that. And sometimes the size is wrong, and NSWOCCs help. I think we're supposed to go down a size rather than up a size. Are you guys changing the sizes of them when you?
Yes.
Are you going up? Like
I believe we're
increasing?
going down.
Yes, we're
I-
supposed to go down. I find a lot of
Yeah.
people want to make the size bigger,
Mhm.
thinking that it's getting blocked or something, but actually decrease it. And other than that, anyone else have a answer for her? I see the NSWOCC sitting back there, and Denise.
Just a sec. Let me go.
Just check the batch of catheters if it's all of a sudden happening. Make sure they're not all the same lot, and then reach out to the company. Sometimes there's equipment malfunction, especially if it's something new that's happening with everybody.
Can I come? That was Emily NSWOCC at the IWK, just saying. And now I'm going to Marcy NSWOCC in Summerside, PI.
Oh, Marcy off on sick leave now. Are they drinking enough? Because sometimes you can get a blockade from crystals or whatever, and they will bypass. So are they hydrated enough?
But it seems to be the catheters themselves. But it could be just coincidence too, that each resident has their own underlying issues, that it seems to be a pattern of things. Yeah.
That would be something you should email Carrie about, maybe.
Yeah, I feel like there's more discussion to be had.
Yeah.
Natalie, George Dumont NSWOCC.
Do you use silicone catheter or the? Okay, because I know that we had experiences with the yellow one, sorry, I don't know that disintegrates like with the urine, so they're not as good as long, so sometimes they disintegrate and that blocks it.
No, definitely. I think you have Carrie's info there. And the thing with us in NSWOCs, like we're nurses specialized in wound ostomy continence. And that's why Carrie here is also a nurse continence advisor. So has always been a source of information for us as well, in supporting us and working full scope, because that sometimes doesn't happen in all of our areas. Is there any online questions?
Oh, Jesus, you're right behind me. Sorry.
Online would like to know why you go down a size versus going up a size when you're changing catheters.
Help, because I know the answer. NSWOCs. Do you remember why? It's something to do with the urine. Go for it.
Oh, maybe. Run into it.
If you think of the urethra as an elastic tube, if you continue to stretch the urethra with a bigger size of lumen, it's going to damage the elasticity of the urethra. So you want to go down a size so that the catheter is smaller, so that the urethra elasticity will hug around the catheter more effectively.
No, you're good. Oh, we have you running now.
What was it?
What are your thoughts on radiofrequency treatment for pelvic floor muscles?
So do you mean like the Emsella chair? I've done that personally. I have stress and urge incontinence. This is Denise NSWOCC in Moncton. Everybody knows I divulge, and beneficial. I contacted our pelvic floor physiotherapist to talk to her about it. It's very expensive. And so you need pelvic floor physiotherapy as well at the same time. It's not an easy fix, because I've benefited from it, but I also need to hydrate because I have definite irritants. But what she said, it would be a great addition to long-term care. If you could have residents sitting on this chair, it does kind of give a snap to the pelvic floor region. And not because you're a man, but they do say men, you generally respond stronger to the chair when it first starts going off, but it snaps and you sit on for about 20 minutes. And so, but yeah, they definitely could see it in long-term care or some of our geriatric units and things like that, but it's a very expensive piece of equipment and you need to regularly do it for so many weeks and then upkeep but have I seen 100% improvements? No, I need to do more work. Yeah. It's not an easy fix. Yeah. I want to introduce our next speaker, and I'm very, very excited for this. We have Dr. Michael Stacey here with us today, who is a vascular surgeon who comes to Canada from Australia in 2014, which I didn't realize, and I love his accent when he was talking to me earlier. As a surgeon in chief at Hamilton Health Sciences and professor in the Department of Surgery at McMaster University, he completed his medical degree at the University of Western Australia, is a fellow of the Royal Australian College of Surgeons, and is licensed with the College of Physicians and Surgeons of Ontario. He's spent a couple years working in St. Thomas Hospital in London, UK, and where he conducted research for his Doctor of Surgery degree. He took on the role of Chief Medical Executive and Executive Vice President Academic at Hamilton Health Sciences in 2018 until mid-2023. And he currently continues his clinical work in vascular surgery and is a consultant for hospitals and biomedical companies in the areas of clinical practice, research, and physician leadership. As well as his practice in vascular surgery of more than 30 years, he has established active research programs in wound healing in both Australia and in Canada. He was the first president of the Australian Wound Management Association. Don't mind me, I get short of breath sometimes when I start talking. If anybody hears it, I'll be fine, I won't faint. And the founding chair of the World Union of Wound Healing Societies. He has a passion for advanced wound care for patients, and he has previously established a multidisciplinary diabetic foot ulcer clinic and a venous leg ulcer clinic in Australia, and is in the process of establishing a similar clinic at Hamilton Health Sciences. So very impressive. His wife is here today too, and she's a nurse, a pediatric nurse at 6 kids years ago, but we have, well, we do have some IWK nurses here, FYI, in case you want to, our children's hospital in Halifax to liaison. You'll see them later on. So we'd like to welcome Dr. Stacy. Thank you so much.
Thank you very much, and thank you for that introduction. And it's a pleasure to be here to speak to you today on the Canadian Consensus Statement on the management of venous leg ulcers. Just quickly by way of disclosure, conflicts of interest, there's some work that I do with different groups. Also, I'm part of Woundpedia, which is a government-funded organisation looking at extending the knowledge on how people manage wounds of different types. So when we set about developing the Canadian Consensus Statement on the management of venous leg ulcers, we had a number of objectives in doing this. And a big part of that was to incorporate new clinical research findings on how to manage wounds, and particularly venous leg ulcers, and how to put them into a practical guide so that clinicians could use it at the bedside. And the key elements you'll see listed there, it's looking at what you would expect, the clinical diagnosis, clinical assessment, investigations, treatments, managing the ulcer. But in particular, what we wanted to focus on was what to do if the ulcer is not getting into that healing trajectory, or if it's a poorly healing ulcer, which often guidelines don't give you that sort of guidance. So you'll see as we go through, that's part of what's incorporated in these consensus statements. The new areas that we wanted to look at specifically, because there are a lot of guidance documents, there are guidelines that are sort of 60, 70, 80 pages long. So we wanted to bring new information into that, but in this concise guidance. So the key things were how to improve muscle pump function. And as we all know, that's the key underlying problem in venous leg ulcers. And there's a lot of new data on using muscle pump activation or neuromuscular electrical stimulation of the common peroneal nerve, and how do we incorporate that into our clinical practice? And there's some data which I'll touch on from a randomized controlled trial from Keith Harding, who many of you will probably be aware of, but Keith's certainly a global leader in wound healing based in Wales. And as I said, we want an approach as to how to deal with wounds if they're not entering that healing trajectory, and then also incorporate the principles of wound bed preparation, or the time algorithm, which many of you will be very familiar with, which has now been around for about 25 years. So if we look at venous leg ulcers, so the key thing that we do with these is try and improve calf muscle pump function, because an impaired calf muscle pump function leads to ambulatory venous hypertension. And that results in a lot of the changes in the microcirculation. You get the swelling, get tissue fibrosis, you get an activation of the inflammatory cascade, which leads to impaired healing. And the hallmark of compression, doing that rather, is compression. And this really is something that even Hippocrates used to advocate for his patients, 2,000 years ago, of binding up the legs and not engaging in horse riding. We don't have to do the latter that much these days, but Needless to say, it's not good for venous leg ulcers. But the key, on top of compression now is that we do have another tool, and I'll touch on some of the evidence of how that improves calf muscle pump function. So that's the muscle pump activator, or you'll know it as the Gecko device, which you'll see out in the trade exhibit today. And I'll just touch on some of what it does. Sorry, there we go. So what is the muscle pump activation device? So it's a little electrical stimulation device that specifically stimulates the common peroneal nerve, which you'll see here. And what it does is it causes a contraction in the muscles in the lateral and anterior compartments of the leg. And it also then results in extension of the posterior compartments. And the main venous return happens within the muscles within the legs. And so this actually stimulates an increase in venous return. And it's recommended to be used for 12 hours a day in patients with venous leg ulcers. And what we know from a number of physiological studies is that it does improve a lot of the parameters, both of arterial and venous blood flow in healthy subjects, and then in subjects with venous leg ulcers, but also the same has been demonstrated in patients who have peripheral arterial disease, so peripheral arterial ulcers, and in diabetic foot ulcers. So these studies have shown that it increases femoral artery, tubular artery blood flow, and it also increases venous blood flow in the femoral and popliteal arteries. So it's actually improving the function of the calf muscle pump. In addition to that, there's also good evidence that it actually improves the microcirculation. So when we examine microcirculation, there are different ways we do that these days, but laser Doppler, transcutaneous oxygen, but there is good information now, good studies showing that both in normal subjects, but in people who have venous leg ulcers, diabetic foot ulcers, and arterial ulcers, that this does improve the microcirculation. And just, jumping ahead a bit quickly. I don't think this is going to show. Just let me see. There we go. So what this is showing you, on the left, you see the normal microcirculation just with the pulsatile impact of the heart, pumping, and the normal sort of pulsatile beat of the heart. But on the right, with this Gecko device applied, you can see that significantly increased microcirculation and the pulsatile effect that this has by an electrical stimulation every second. And when we measure those parameters, both in the wound bed and the area around the wound, there's a significant increase in the perfusion and the pulsatility related to this. So definitely good evidence that not only does it improve calf muscle pump function, but it improves the microcirculation as well. And the thing about microcirculation and tissue hypoxia is that there is a lot of very good evidence as well from many years of study with transcutaneous oxygen and laser Doppler that patients with different types of leg ulcers have reduced microcirculation. Both of those techniques have demonstrated that consistently in many, many studies, I'd say in the last 25 to 30 years. And what we also know, and I'll just focus on venous leg ulcers now, is that when we use compression, which is our standard treatment, and whatever type of compression we use, but these days, multi-layer, mostly short stretch, sometimes long stretch bandages, that also improves microcirculation based on transcutaneous oxygen and laser Doppler. So our standard method increases it, and we have this additional method of doing it. And the question really is, where do we position that in, how we manage these wounds? And that's where we're trying to incorporate that in this document. I'll just give you some of the evidence really behind the clinical usage of the muscle pump activation device. And this is a study done by Keith Harding and his colleagues in Wales. So it was a randomized controlled trial looking at the use of the muscle pump activation device in addition to standard compression therapy compared to just compression therapy alone. This is really just a design of the study. So they recruited patients with venous leg ulcers that were venous leg ulcers without other things like arterial disease or other significant factors. They had a 4-week run-in period, so patients went into compression in the whole cohort of patients. And then after 4 weeks, they randomized them to carry on with compression or to add muscle pump activation to compression. And then they followed those patients for 4 weeks. And within the study, they followed them for additional 4 weeks. And they had a follow-on period that carried on for another 3 months. So they got data on really how effective this was over effectively a 4-month period. Just to show you, and it's always the case with randomized controlled trials, you want to know what sort of patients were they dealing with. Were the two groups effectively similar? This is just comparing the two groups so that there is the standard of care compression, the SOC on the left, and then the SOC or added NMES, which is neuromuscular electrical stimulation, or the muscle pump activation device, also known as GECKO. And you'll see probably two things to point out. One is that the wound size, these were not small ulcers. The average size there in the two groups was around 10 square centimeters, which means you'll have some small ones, but some quite a lot bigger than that. And also the duration of these ulcers, you can see these had been there for a long period. In the standard of care, 480 days, that with the muscle pump activation device, 530 days. So these are long-standing. These are not just your easy, simple ulcers. But no difference between the two groups is the other significant thing to point out here. So when they looked at their study and that initial run-in period, when the ultimate two groups had the treatment with standard of care compression, this is looking at the percentage area reduction in the two groups. Slight little bit of difference between the two, but not statistically significant. So they're similarly responding to compression. And then this shows you in the subsequent 4-week period how they responded. And on the left, you see is the standard of care compression, and on the right is the ones that had the muscle pump activation device. And what you see there is a statistically significant increase in the healing rate. In other words, the increase in the percentage area reduction in those that received the muscle pump activation device, in addition to standard of care compression. And this is just showing it in a slightly different way. What they also looked at, they calculated the rate of ingrowth of the epithelium from the edge of the ulcer. And what you see in that graph on the right-hand side is the run-in period is that grey solid line. And then halfway through after the intervention, those in the standard of care compression in the dotted line carried on much the same trajectory of the rate of ingrowth. But those that received the muscle pump activation device, you see a significant increase in the rate of ingrowth. So what this study is really telling us is that when you add this to standard of care compression, and what it does, it helps calf muscle pump function, it actually adds to what we get with compression in terms of improving healing. So certainly a significant outcome really from the study that this group did. This is just one of their patients, just showing you on the top line, the first 4 weeks, definitely some gradual improvement. But on the bottom line, you see a much more rapid improvement in the healing of this particular wound. And just so you're aware, there is some Canadian experience in looking at studies, not exactly the same structure, but Holly Murray and her group looked at a cohort study. So they looked at a group of patients prospectively using standard of care compression with the muscle pump activation device and compared them to a retrospective group of patients who just had compression. And you see at the bottom what they found is that the mean healing time in those that had the muscle pump activation device was 40 days, whereas with standard of care compression alone, 77 days. So showing something similar to what Keith Harding's group had shown in Cardiff. The other thing that we wanted to incorporate here was the principles of time, which you'll all be very familiar with, and you'll see that when I go through the consensus statement, but really wanted to make sure that we incorporate, excuse me, the principles of managing the tissue, so debriding any devitalized tissue, dealing with any infection or inflammation within the wound, which is a key part of how you address the wounds, dealing with the moisture so the wounds are not too moist, not too dry. And then the E part or the edges, well, what do you do when that wound edge is not advancing as it should do? So what strategies do you have there? So this is a theoretical construct that has never really been largely put into practical application, particularly the edge part of this. The other parts I think you're all very familiar with doing, but this part of this consensus statement is how to give us an approach to what to do when this is not advancing as it should do. And part of that is to look at an algorithm of advanced wound therapies. And this is some work that I'd done a few years ago, and a few others have been involved in this type of work. Is we have 1,000 dressings out, sorry, probably more than 1,000, many thousands of dressings out there available to us. The question is what to use and when. And when you look at all the dressings that are out there, there are a lot that deal with those, T, I, and M components of the wound bed preparation. But what other ones do something active to the wound that actually may stimulate the healing process? And so when you look at those dressings, there are several groupings that you can look at. So one is to look at dealing with bacteria and biofilm, and there are dressings that do those things for us. And an approach to this is say, well, how do we deal with this in a sort of an algorithmic step-by-step process? And this is just one logical way of looking at it. If the wound's not healing, think about dealing with the biofilm and the bacteria. Assess it. If it's still not healing, then look at how do you reduce protease activity, which is a significant problem in these wounds, and there are dressings available to do that. If it's still not improving, you've dealt with those things, then what do you do with the wound bed to encourage that, to be more vascular and more able to accept cells to pass across the surface? And we have a few options: negative pressure, using matrix substitutes, which can help stimulate that wound bed. If it's still not improving, you've got a good wound bed, you've reduced proteases, not much bacterial contamination, then adding growth factors. And the reason you add growth factors at this point is that if you don't have an adequate bed for cells to come across, then growth factors are not really going to help you greatly. If you have increased protease activity, it degrades growth factors and their receptors. So that's where it fits in. And we don't have a heap of options in growth factors out there at the present time, but there are some, and this would be the time to use them. And then finally, if they're still not improving, you've done all of that, then what you want to do is to add new cells to the wound. So this can be different ways: standard skin grafts, can be stem cell transplants, can be cultured epithelial cells. Not a lot of this is available to all of us all of the time, but there is a time at which you get to a point where that's what you want to look at. So come to the consensus statement. So how do we go about developing this? So we had a group of 19 healthcare providers that we pulled together from across Canada. This was led by myself, Gary Sibbald, Keith Harding, and Robin Evans. And we wanted to look at people who had some experience with some of the new therapies, with the muscle pump activation device, wanted a spread of physicians, nurses, therapists, different areas of Canada. We went through a process, which I won't go to in great detail, but basically we looked at developing a draft consensus statement. We had the panel review it. We broke it down into different components. Then we had a rounds of consensus to see if we could achieve 80% consensus on each of the elements within that document. We had 23 sections. We got 100% consensus by the end of this on 20 of them, and greater than 85% on the remaining 3. And this was done independent of any input from any wound care companies. So it was really the thoughts and the ideas of that panel. This is the panel, which you can see listed there, and you'll be familiar with some of them from this part of Canada. They've been from different areas of Canada, a number of physicians, quite a lot of NSWOCCs, and at least one therapist within the group. So I'll just go through some of the components there, and the key elements, as I mentioned before, is one, how do we go about diagnosing venous leg ulcers, and what is a venous leg ulcer? So we had this initial statement, which I won't read through, but it's really looking at how do you personalize this to the patient's situation, the patient's needs, the patient's goals, what's available to them, and how do you then go about assessing that? Part of it is to look at the clinical features, the location, the ulcer appearance, the surrounding skin. Again, things you'll be very familiar with, so I won't go into detail on those, but they're included in the document itself. And then investigations. So how do we go about making the diagnosis? And, venous leg ulcers, a lot of it's clinical, but then we do need some objective evidence that this could be a venous leg ulcer and not something else. And the key things, as you'll all be familiar with, is to make sure you know your arterial status. And so doing ankle brachial pressure indices, or in some areas where that's not available, they may look at, audible waveforms on a handheld Doppler, but something that tells you what the arterial blood supply is like. Because you want to know that if you're going to apply compression as well, and it'll guide you as to what level of compression you might use. Venous, you want some assessment of venous disease, and these days that's mostly by a duplex ultrasound, not always readily available to people. But if you've excluded other causes, your ankle brachial pressure indices, you may not have got an opportunity for a venous ultrasound, but the clinical features fit with venous disease, and it's appropriate to treat the patient at that point, while perhaps getting a venous ultrasound later on. The other thing about the venous ultrasound, it also can guide you as to what you might do in your treatment as well. And then you do other blood tests, just looking for other potential clinical problems that may impede the healing process, or there could be other causes of ulceration. And we also want to know something about the gait and the ankle movement, because that can also impede the calf muscle pump function. So when we're treating venous leg ulcers, the real crux of treatment is to treat the underlying causative problem. And this is what I mentioned before. It's the calf muscle pump function that's impaired that we really need to treat. This is why our standard of treatment has always been compression therapy for these types of wounds. So this compression is treating that underlying problem. Now, we have to be cautious with the ankle brachial Doppler index. But if it's greater than 0.9 and within that 0.9 to 1.4, because above 1.4, they've got incompressible vessels, so it may not be accurately assessed. Our goal there is to use some form of compression. And as I mentioned, there are different methods that we have, you'll see them in a box these days, but before boxes came around, we all had our own strategies for how to do multi-layer compression. There are different systems, the ones with the hook and loop fasteners, which are quite suitable for some patients. There's also pneumatic compression devices, other compression socks. So the selection will depend a lot on the patient, the individual, their ability to wear them, to have them put on, tolerate them, etc. We also encourage calf exercise. So the simple thing there is often just walking, and sometimes a walking program to encourage calf muscle pump function and the venous return. So they're the basics of what we do. But what do we do if the patient can't tolerate compression, or in some cases, they actually have a lower arterial ankle brachial pressure index? So generally, if they can't tolerate it, we still want some compression. So what we'll often do is go down to a lesser level of compression. And you probably all know most of the standard compression devices is the standard type, and then there's the light version. So the light version gives less compression. So that's where you'd go to something less. And even, in some patients can't even tolerate that. So you might go to a stockinette or something like that. But when you go to that, if it's more just a matter of tolerating it, then your goal is eventually to get them up to full compression. But of course, patients who've got reduced ankle brachial pressure indices, we want to use that lower level first. So that's where we want to go because we don't want to cause any harm. But the key here, now that we have this additional method of treatment, is that if we have to reduce that because they can't tolerate compression, we know we can improve calf muscle pump function by adding the muscle pump activation device. So if we have to drop back the level of compression, this is the ideal opportunity to be able to introduce that to get better improved function of the calf muscle pump. So whether it's because they can't tolerate it, whether it's because their ankle brachial pressure indices don't allow them to be able to wear it for risk of damage. So whatever the cause is, if you're having to go to less compression, then, because we now have this opportunity, which we didn't have, 15, 20 years ago, or when I was a medical student, or even a young person opening wound clinics, we didn't have this opportunity, but now we do. So it's an additional thing that really helps us as clinicians. We still recommend exercise, and for those patients who have difficulty wearing compression, even elevating their legs several times throughout the days just to reduce the level of edema and swelling in the leg. And then, of course, that's treating the underlying problem. Then we have to treat the wound itself. So we've got two components there. And with treating the wound, we look at, as I said before, those time principles. And we do a number of things, so simple things, just like cleaning the wound. And, traditionally we've used saline or even just, potable tap water. But we do have some really good wound cleansers now, the hypochlorous acid type cleansers, which can be used because they're fairly rapid and effective antimicrobial. And they also break down biofilm. So very effective at cleansing the wound. Then we want to go through, so those first three things I've highlighted in red. So the first one is the T of time. So debriding any or removing any devitalized tissue. Second one is looking if there's any evidence of infection in the surrounding tissue, then you want to treat that. If they're actively infected, you want to treat them with antibiotics. You may add antimicrobial dressings. And then you want to ensure you've got the right moisture balance. So not too moist, not too dry. And there you've got multiple dressings that allow you to go to one way or the other, depending on which one you need to address. The other things we have to do, of course, with these patients is manage their pain, because some of these patients have quite a bit of pain. We want to treat the surrounding skin because that can be irritated sometimes by dressings, by moisture, or sometimes they've got very dry skin, skin that has other reactions. And then sometimes we get to patients, to wounds that, they've had lots of treatment for a long period. People feel that they're not able to achieve healing. Then you can have strategies for how to deal with those as well. The one key point, which I've highlighted in red at the bottom, is we should always measure these wounds. And at each visit, or at least weekly, depending on how often you see them, so that you know what's happening. And I always recount my experience with our residents in the hospitals. We have patients coming to surgical outpatient clinics. In the notes, wounds getting better, wounds getting better. 6 months later, wounds getting better, wounds getting better. There's not a measurement in sight. So how the hell do they know the wound's getting better? Short answer is it's not, if it's still there in 6 months. So measuring is really a key part of how you manage venous leg ulcers. So then what do you do if the wound's not progressing? Because, this is a standard. Many venous leg ulcers respond to the compression or dealing with the calf muscle pump function, a good approach to managing the wound, but some of them simply don't improve. And there are a number of definitions of, how they're not entering that healing trajectory. It may be no size reduction in 2 to 4 weeks. Some use less than 30%, reduction of 30% or more at 4 weeks indicates that there are a healing trajectory. So if the patient's at this stage, there are a bunch of steps you should do. The first thing is make sure your diagnosis is correct. So you might have missed something. This could be a skin cancer. This could be some sort of autoimmune condition. They may be on other medications that are impeding healing. So just go back and review the situation. Then if you're sure your diagnosis is right, then have a look and see if what you're recommending is actually being utilized. So is it being applied? Although you might be recommending standard 2-layer or whatever layer compression, the patient may not be having it. They might be taking it off. The community nurse might not be putting it on because they don't want the patient to wear it for their own reasons. So make sure they're having that. If those things, if they're still getting that, the diagnosis is correct. You've reassessed the compression, make sure it's the right one. They've got a walking program as well, an exercise program. Then here is your opportunity to further improve the calf muscle pump function using a muscle pump activating device, using the data from Keith Harding's study. It tells us, so this is telling us, okay, Keith's study looked at everybody, but here, at very least in those who are not responding, with everything else being venous, got the right treatment, they're not responding, this is an opportunity where we really should be adding that muscle pump activating device because the data tells us healing improves when we do that. And we may also want to consider something like surgical ablation if they're suitable for that. We may have considered that at the beginning, but again, you visit that at this point when you're reassessing. And then the other approach, so let's say you've done all of that, you've got everything in place, you've added the muscle pump activating device, it's still not healing. So what do you do there? So this is when you look at that approach to the advanced wound dressing. So you've treated the underlying problem, you've got the right diagnosis, then how do you do something extra to make this wound heal? And this is where you have this approach to really a stepwise approach to using some of the advanced wound dressing. So even though the wound's not infected, you still want to do something about the bacteria in the biofilm because that can have a negative impact on healing, even though it's not infecting the wound. So that's where it's used in that sort of setting. Still not responding, as I mentioned before, you go to reducing proteases. Still not responding, you do something with the wound bed. Still not responding, look at adding growth factors. Still not responding, somehow add some healthy cells to that wound. There are other adjunctive therapies, some of which I've listed there, some of which have an application for different types of wounds, not a lot of data for their use in some wounds, in venous leg ulcers. One oral pentoxifylline, there's some data for that use as an adjunctive therapy in venous leg ulcers. But certainly you would also consider some of those as options if you're still not getting to where you want to get to. And then the ultimate thing then, once you've healed this wound, which eventually you will, unless there are those patients who really just simply can't get to that point, the key then is doesn't stop then with venous leg ulcers because these patients' wounds keep on recurring. So you need to look at compression therapy really for life for these patients. You may also consider, do they need their veins treated if it hasn't been done? But again, that depends on what you find on your ultrasound study. So we look at lifelong compression and we may, have to tailor that to what the patient can tolerate. But ultimately, whatever they can tolerate is key for these patients. And in most cases, it's below knee compression stockings, and in most cases, 25 to 40 millimeters of mercury. But we have other compression options if needed. We still encourage exercise, calf muscle pump exercise, and we have to, reinforce education about what to do if they develop any wounds. I'll just give you an example of a patient which I think sort of exemplifies quite a few of the things that are within this consensus statement. So this is an 89-year-old, fairly active female patient with not a lot of other health problems, had a bit of diabetes, bit of hypertension. She was referred to me from one of my colleagues. By the time I saw her, she'd had a venous leg ulcer for 12 months. 6 months before, she'd had her veins in that leg treated by EVLT or endovascular laser therapy, so treating the superficial vein, obliterating that, which if you've got an incompetent vein, that can add to the poor healing, so that can help. She was getting some compression, but not consistently good compression. And over the 6 months before I saw her, her wounds had actually been getting bigger. She was getting a lot of pain from this. She had good ankle brachial pressure indices in that right leg, good toe pressures. So standard approach then is to look at adding some compression. So one of the key things was to get her into consistently into good compression wraps. So she had good 2-layer, full level of compression wraps. We used an antimicrobial, antibiofilm dressing at that point because the wound looked, while not infected, looked a little bit contaminated. And you'll see on this graph, this is really from the time that I saw her. There was 12 months before that. So once we got her in, and she had ulcers on the medial and lateral sides of her leg. That's why you've got 2 different graphs there. So once we got her into full compression, the bigger ulcer on the one side actually increased in size a little bit. The other one on the lateral side reduced. And you'll see this is sort of, both of them are starting to improve. But when you look at that sort of 7-month period, she'd had quite a lot of pain, still 7 out of 10 pain all this time. And if you look at what's happening to this wound in the 3 months before that 7-month one, it's only increased 20% over 3 months. So you've got good compression, you've treated the veins, she's actually got an antibacterial, anti-biofilm dressing on. So this is, from the algorithm, this is the obvious point, and probably should have been earlier, but the obvious point to add the muscle pump activation device. And what you can see on this graph, if you look at just the top one, because that's the bigger ulcer, the slower to heal one, once we did that, healing started to improve. We only did it for 4 weeks. It improved, still not at the rate that we would like. The pain reduced, but then after stopping it, the pain started to increase again. So we added it again. And then when we added it the second time, you'll see it's significantly reduced. The pain also reduced, and it progressed to healing. The smaller one on the other side of the leg was, responding probably on a better trajectory, still not quite at that 30% in 4 weeks that we're looking at. And you can see it improved. The other thing with this, if you look at the dotted lines, what the dotted lines there is showing you, had we not added the muscle pump activation device and had it continued healing at the rate it was, healing would not have happened for at least 6 months after it actually did heal, the bigger ulcer. The smaller one was probably an extra 2 months. But when you think of that, you can reduce the duration of ulceration for a patient like this with 6 months. Not only does it help the patient, but it helps the cost. It helps reduce the cost, to the community, to your health care facility, to your health system. And with that, and whether it's muscle pump activation device, whether it's the right dressing, whether it's the right compression, all of those things are going to help reduce the cost. But we have good data from Keith's study on, how muscle pump activation device improves healing. And Keith's group also did a cost effectiveness analysis. So we also looked at those data and looked at some Canadian costs of healing or treating venous leg ulcers. And extrapolating Keith's data into the Canadian setting, what we looked at here is the standard of care. You'll see in that first box on the first line, the average time to treat those patients was 234 days. With adding muscle pump activation, 178 days. So definitely got an improvement of roughly 56 days of less ulcer for the patient. We got a consensus group together of Amanda Loney, Connie Harris, and Graham Cork, who's a statistician. We looked at what is the average cost per visit of treating a venous leg ulcer in Canada. We got a number of just over about $110 per visit. And that's the patient coming to a clinic. That's not a home visit. In the UK study, their number was probably around 130, roughly. So we know we're in the same ballpark. We may have underestimated a little bit. But if you apply those data to the reduced number of days and you allow for the cost of the muscle pump activation device, you've roughly saved $1,000 per patient, and they've got 56 less days of wound. The bottom graph is really looking then at those patients who have long-standing ulcers, so not healed in 12 months. And oftentimes those, if you carry on that same trajectory, they won't heal in the next 12 months. Some other data from the UK are suggesting with those patients, if you put them into continuous muscle pump activation with standard of care compression, they'll heal on an average of 2 months or 60 days. Now, if you look at the cost of that versus the cost of treating them for essentially a full year, you're saving $10,000 a patient. So, those hard to heal ones, that there is significant reason to do the right things. And this is doing standard of care, but then adding something like this in those ones that we know. And that's like that patient that I showed you. Her wound had been there for a year before I saw her. So she really needed some significant intervention. And just a final slide, just to show if you project that out, across Ontario where I live, or across Canada, with those populations, and based on some international data on the prevalence of venous leg ulcers, roughly 0.32 is a sort of a collated assessment of prevalence studies. By the way, one of those was one we did in Australia about 30 years ago. There'd be roughly 50,000 people with leg ulcers. If you equated that to the savings on treating those, $50 million a year. If you look at the hard to heal ones, and, based on a 20% data, which a number of studies have identified that in venous leg ulcers, you treat those patients roughly $100 million a year. And you expand those numbers to across Canada, you can see that with just treating those, the patients with venous leg ulcers, at the times that we pointed out, you'd save 140-ish million, and the hard to heal ones, 275. So there's $400 million could be saved in the Canadian healthcare budget by appropriately addressing treatment of these patients. So lots of opportunity, and obviously, here in New Brunswick, smaller population, but still you would get the same sort of levels of savings here comparatively. So I'll finish on that. Happy to take any questions. If any of you want to access the consensus statement, I think some of them have been distributed. I think there's some on the table, but there's a QR code there that you can go to. It's an independent website. It has a copy of that you can download for free. This has also been endorsed by the NSWOCC and also by the Canadian Home Care Association. And there's a publication that we published last year and early this year, I think, in the International Wound Journal, which contains the whole consensus statement and the process around how this was developed. So thank you very much, and happy to take any questions.
Have any? Nancy, you have a question?
It was great presentation, lots of good information. If we're seeing if those projected cost savings are there, why aren't we seeing it used? Is it the initial price that shocks systems that prevent it? And is it being used in Ontario? Because I know in New Brunswick, to my knowledge, it's not being used widely.
Yeah.
But
so I think as with any new technology, there's two elements that probably impede its use. One is firstly knowledge and people understanding where it fits and where its application is. And within this consensus statement, we've been somewhat conservative in terms of how we recommend it. We're recommending it for those that have hard to heal wounds and those that can't tolerate compression. But if you extrapolate from Keith's study, he's saying if you use it on all patients, you'll actually get much more improvement. But we're trying to get people to understand that, that there's a place at which you can begin, be comfortable with it. So that's one, people having an awareness of the use. The second one is it does come with a cost. And not when you look at the cost of treating leg ulcers, and that's why I showed you those last few slides, like you actually save money by using this. But of course, any funder obviously balks a little bit at cost. And the cost in Ontario is roughly $1,500 for four weeks of treatment. But if you offset that with reducing the time of healing, then you've actually significantly saved money. That's $1,000 a patient if you use this. So, it's a trade-off. And thing is, that $1,000 per patient, you don't realize that back usually as money in the pocket for the funder. But what it does do for the funder, it creates capacity. So you've got more capacity for treating other patients with other problems. Or if you do need to downsize, which there is always a pressure to downsize, then you've got opportunity to do that. Not that that's the goal. The goal mostly is to create capacity, because we all know there's often lots of patients waiting to get treatment. So it's multifactorial. And I think in Ontario in particular, it was on the formulary for a lot of home care. They created a new formulary for some reason, a provincial-wide formulary. It didn't get on that for some weird reason. So that's impeding its usage. So either patients pay for it, or their private insurance pays for it, or if they're in long-term care facilities, they do pay for it. But it's the people in the community that really struggle to get it at the moment. So that's why, I think when you look at the potential benefit to patients, that's quite significant. And added to that is a reduction in cost. So it should be a no-brainer, but things never really are with, health funders. Because they deal in silo budgets, because they don't want to spend in their budget and someone to save in their budget, because they can't work how to sort of, reconcile that. I hope that answers the question.
And Nancy, we did use it in the Miramichi. Tracy is aware. There was a gentleman who had his wound for 32 years. And he was in compression wraps for 32 years, and the nurses were going in 3 times a week. And we got him healed. I think it was 10 weeks, and then he opened a bit. So they continued for another 6 weeks, gave him like that extra couple of weeks. That was in 2019. And I spoke to one of the nurses in 2021. He was still closed. And so I think he might still be, Tracy, or yeah, he's still closed. So after 32 years, it worked. Now, the other thing I want to make mention of is that Gecko is available on MedBuy. And so it's available. It's just there has been no uptake at the present time. Pardon me? Well, the cost for one pack is $750, which is $375 a week. But when you do the math, and what Dr. Stacy was saying, like if you have somebody for 32 years and you get them closed in 16 weeks, and I just had one case in Ontario that we're doing an abstract with, and this particular patient was 416 weeks on treatment in a long-term care home, and they got him healed in 16 weeks. Yeah.
I think, Kathy, you kind of answered this a bit there, but it just said, is it recommended to continue MPA after healing?
But
One sec, because they won't hear you. This is just my own clinical experience, is that if you give them an extra couple of weeks after they're closed, it seems to really give that extracellular matrix more strength. And again, the case in the Miramichi, where this gentleman, they did give him an extra 2 or 3 weeks, and here he is, 2025, and still closed 6 years later.
maybe just to comment on that as well. I mean, I think basically when a venous leg ulcer is healed, you normally do, when you think it's epithelialized, you normally do carry on compression for a few extra weeks to allow that to consolidate. But once it has healed, the standard is to go into some sort of compression, so compression stocking. So to Kathy's point, you might continue it as part of your regular treatment, but once you've got to that point, then you go into compression. That's the gold standard. If they can't manage compression, and if there's someone who keeps getting recurrences, then you may consider it in that sort of situation as well. You know, it sort of has a number of uses, but I think generally once they're healed, compression is the gold standard.
Is this something that if we had access to, the NSWOCC could order, or is it a physician order?
Yeah, so I mean, I can speak to that, but maybe some of the others would like to. In general, it is something that an NSWOCC could use. I mean, generally, they often like to have a physician recommend it. So probably, and particularly in Ontario at the moment, it's not available to them in the home care. So physicians need to recommend it. It has some special approval process, which does need a physician in there somewhere. But ultimately, once it gets into the regular system, just like putting on compression, there should be, you know, if you're thinking that nurses are appropriate to start compression, then they would be appropriate to start this. But it's not, the system hasn't got to that just yet, is probably the answer. But ultimately it should. Yeah.
Anybody else? Yeah. 1 second.
She walked past you. Yeah, she wasn't going to let you ask that question. Yeah.
So this might be a little bit of an offensive question, but I was just wondering if there was any comparison between just a regular eStim device versus the Gecko. I also have another question, if that's possible.
Yeah.
And I was just wondering too, if we can exclusively rely on a toe brachial index without doing an ABI prior to on diabetic or non-diabetic patients, or do you always have to do an ABI before and then a TBI after?
Yeah, no, that's two good questions. I'll deal with the first one first. So there is a fair bit of confusion around the difference between this and the eStim or electrical stimulation device. So maybe just firstly to say, the similarity is in the name, electrical stimulation. The reality of what they do, they're completely different. So what this device does, it stimulates the muscles in the leg to contract and improve venous and arterial function and microcirculation. What the eStim or electrical stimulation device does is you put electrodes around the wound, you create a current across the wound, and the concept is that that increases some of the biochemical activities that are involved in wound healing. So completely different technologies, completely different approaches. That, you know, people get them confused just because of the name. But the evidence and the data for eStim in venous leg ulcers are not as great as the evidence and the data for use of the muscle pump activation device. That's why people are now trying to call it the muscle pump activation device, so it's very clear it's not the same product. So yeah, confusion, and even we think that's part of why in Ontario, like it's not on the formulary because they've got it confused with eStim, which is kind of silly when the people making the decisions don't know the difference. Sorry, and your second question was, oh yeah. So no, that's a really good question. I mean, the basic standard mostly is to use ankle brachial pressure indices because that's easier to do. You just need a blood pressure cuff and a handheld Doppler. But as we know, in patients who are diabetic, often that's elevated, artificially elevated and inaccurate. So, so mostly people will do that in the first instance because that's what they have available. The toe pressures, you usually need some other, you can use a PPG device is probably the most common one used on the toe, but you can use other things like transcutaneous oxygen. You can even use laser Dopplers for that. But if your ankle brachial pressure index is abnormally elevated, then absolutely you go off the toe pressures. The difference there is like, I mean, what happens with diabetic patients, but not only diabetics, some other patients with significant arterial disease, the vessels, the tibial vessels are not compressible with the cuff. So you can't compress them sufficiently to get an accurate blood pressure. When you go down to the toe, there is less significant calcification in the digital arteries. So the little cuff that's put on the toe is able to compress that. And what you see is the pulsatile flow on the PPG, and you see that drop off. So you see that come back when you get to the pressure. So the toe pressures have a different range. So just so people don't get too confused, ankle brachial pressure index 0.9 to 1.4. A normal toe pressure is 0.7 or above. So if it's 0.7, 0.75, don't think of that as being low. That's actually normal. So that there's a bit of education as to interpreting toe pressures. Does that answer your question?
Toe pressure, sorry, if you had the toe pressure device readily available to you,
Yeah.
and you would do that for all your patients to check the vascular, would that be appropriate, or would you still go for the ankle brachial index?
Yeah, well, I think the standard currently is most people go for the ankle brachial pressure index, but a lot of places will do both.
Okay.
But if the only thing you had available was a toe pressure, absolutely use that. I mean, there's no reason to not use that because that's still a very accurate measure. And, if, for example, if a patient had a wound as with a venous leg ulcer and you can't put a cuff on that wound, then for sure do the toe pressure. Yeah. So, and there are a lot of patients who you won't put a cuff on because they've got a big, exudating wound down there. So.
We'll do one last one. So Nancy wanted to know, why aren't vascular surgeons ordering it in our area?
That's a really good question. The short answer is probably because they're not. The second answer is that they don't really have an understanding of of the device. Many of them don't even know what the device is. Secondly, they don't really understand where it sits in the overall management of venous leg ulcers. So to that end, I mean, I presented at a vascular conference. They have a winter conference in February and presented some of the evidence for using this type of device, not only in venous leg ulcer, but also diabetic and arterial. Next week is the Canadian Society of Vascular Surgery conference, so I'll be presenting there as well, giving them some information. So providing them the information, like that's the first step for them to even understand what it is, because most people, I tell them ask them about the Gecko device, they kind of think of a little thing, creeping up the wire mesh windscreen, fly screen. But then, once they have an understanding and once they see, because they see some of these very difficult patients, they have no idea what to do with them. They send them to the nurses because they have no idea. But if we can give them some tools that can make them look smart, and they might start using it. Yeah, that's a cynical answer from a vascular surgeon.
I wish I could listen to you a lot longer, actually, Dr. Stacy, because I've learned so much and I'm actually eyeing colleagues in the room about things that we do need to, work towards, including a physiotherapist that we have here today. But I wanted to give you this gift. A little birdie told me that you liked red wine, but it's East Coast red wine. So I'm not sure. Let me know. There's a bottle of white too, but we want to thank you very, very much for coming today. We really, really appreciate it. Thank you so much. It was wonderful. Okay, so next up, we're just a couple minutes over, but it was wonderful to have Dr. Stacy presenting for us. So, and some wonderful questions that actually answered questions that we had as well. So, because we'll, as per policy, ask for ABIs, and then Melanie and I have a machine, and so we're able to do the TBIs, and so that tends to be the process. Is if they are unable to get a result, then they'll consult us. So, so our next presenter, right? You're next, yeah, is the wonderful Andrea Gallagher. I met Andrea not too long ago, but I feel like we need to talk because we were both working at the Chalmers in Fredericton at the same time. So we've probably crossed each other's paths. But Andrea works in Fredericton with Mary Barton. Andrea is a SWAN at the Dr. Everett Chalmers Hospital, and Mary Barton is an NSWOCC there. And she has a vast history of education. And so we are fortunate that she has pursued the SWAN course and is actually in a SWAN position. And we've had several positions created throughout her horizon. And I think everybody's here except for maybe Patty from St. John in terms of swans. So Andrea's gonna, oh, someone's clapping online. I can see little comments and I love that. I was smiling earlier. I could see it while you were talking, Kathy, they were coming up. But I want to bring Andrea up. She's going to do some ostomy education for us. So without much further ado, Andrea Gallagher.
Thank you, everybody. It's a real pleasure and an honor to present to you today. And this is my first time presenting, so I may be a little nervous. Okay, let's begin. Ostomy 101. So today, what I'd like to do is just talk about the role of the NSWOCC and what the SWAN does when it comes to ostomy care. What is an ostomy, and what is a stoma, and different stoma types. What we're going to choose for a product for our patients. We're going to talk about some tips and tricks that are very helpful when we're working with our ostomy patients on the front lines, because I have been there. And how are we going to support our ostomate? So to begin, I'm going to discuss the role of the NSWOCC and SWAN. So the NSWOCC and SWAN work together to deal with diverse needs of the ostomate. The NSWOCC only will be consulted to mark our ostomate or potential ostomate. Some people go in for bowel surgery and may end up with a stoma, so they like to pre-mark just in case. So they go in and they do some teaching, some early teaching and some markings to just get them prepared. It's actually very beneficial for the patient to prepare as opposed to an emergent surgery. It's very traumatizing. And when it's an emergent surgery, when they're not mentally prepared, and even when they are, they can get it can be very traumatic for them. And post-operatively is when the SWAN or NSWOCC can go in and do teaching with the patient and also with the staff. So when you're dealing with education, we go in and we encourage them and we measure and do a lot of things to get them prepared. We educate everyone and the families. We do problem solving. If there's some leakage or different issues with product, we can help with that. And we also bring forth the current best practice in the ostomy community. It's always an evolving role. So we're always there to bring that forward and teach the patients and staff the best practices. Okay, so I think we can all relate to poor Winnie after a turkey dinner, that people struggle with body image. So just imagine you're struggling with your body image already, and then you wake up and you have an ostomy. And how would you feel? Would you want anyone to know? What if it leaked when you're out somewheres? Would you go to a dinner? Would you even go grocery shopping? So it's a very traumatic thing for our patients. And it's just really important to think about that when you're working with these people, to be very mindful. So the next is ostomy versus stoma. So an ostomy is a surgically created opening in the abdominal wall that results in the external diversion of feces or urine through a stoma. But then the stoma itself is also the Greek word for mouth or opening, is the most commonly refers to a piece of bowel which has been brought through the skin to the surface of the abdomen, where your stool or urine will come out. So in the anatomy, the digestive tract starts at the mouth and ends at the anus. Your stoma is the same tissue as what's inside your mouth between our nerve ending, but without nerve endings. So the tissue is very adaptable and versatile. And so when we're cleaning it, it's important that you can be firm but gentle. You don't want to damage the stoma. And there's no feeling on your stoma. The feeling is all around the edge of your skin. So when your patient is saying they're applying, or their skin is sore or their stoma hurts, it's usually a sign that there could be some damage. So ostomy types. There are different variants of ostomies, but we're gonna, for all intents and purposes today, I'm just gonna say there's 3 different types for basic. So there's a colostomy, which is the large intestine, and there's different sections of the colostomy. Your stomach can be like your transverse, your descending, or your sigmoid. There's an ileostomy, which is in your small intestine, and then there's a urostomy, which is a diversion, usually from bladder issues, when your bladder's removed to help filter out your urine. Oops, there's my pictures I should have mentioned as I was doing that. I'll get better, I swear. So first I'll talk about the ileostomy. So it's from the small intestine. It's responsible for digestion and absorption. The further along the small bowel, the more nutrition and bile salts are absorbed. So most people have an ileostomy if, as opposed to a colostomy, mostly because of bowel disease. Often they can have more bowel removed. So there's different issues with nutritional problems and digestion and absorption. So sometimes they're a bit more emaciated. The peristaltic movement in your small intestine is like small waves. So you're constantly, it's constantly passing liquid stool through. So your ileostomy will produce more stool more often, which is an important thing to know. So you should really be continuously checking it because you're going to need to empty that product or encourage your patient to empty their product more often. Or you'll have a blowout, and nobody wants that in 3 a.m. With the colostomy, it's in the large bowel, and it's responsible for the water absorption and storage of fecal matter. The large bowel causes fermentation of food, which produces gas, which is often your smelly ostomies when you're changing. This peristaltic movement is much different. It's more of one great big wave, like it would be when it's evacuating from your rectum. So it doesn't move as often. And sometimes people only have maybe 1 bowel movement a day or 2 compared to many over the day with an ileostomy. So an ileoconduit or a urostomy is called an ileoconduit because it is created from a piece of the ileum, which is part of your small bowel. The tissues of the ileum produce mucus, and they continue to do so even when it's made into the urostomy. So you're going to notice in the pouching that there's a lot of mucus, and some people mistake that for a UTI. So it's important to know the difference because if you look at your Foley catheters, often there's not a lot of mucus in it. So when you see that, people will send urine specimens off all the time and mistake it for an infection when it's not. So you kind of have to know the difference. So your bladder, just as a comparison, expands to hold large volumes, so it can hold 300 to 600 mils of urine. And your nerves would stimulate the bladder to expel. But an ileoconduit can't do that. It only acts as the buffer. So your ureters attach to that and filtrate out into the bag, and it's always peeing. So be mindful of that when you're changing your bags or in your appliance. I take a 4x4 gauze and roll it into a Tootsie Roll and put it on top to hold it to absorb that. And it's a good way to prevent it from peeing all over and making everything wet so your appliance doesn't stick. It's very important, as I'm sure you know. So with new ileoconduits, when created, the ureter swell like your bowel would. The swelling prevents the passage of urine to come out, so they put stents in. And some stents are put in and held by the swelling, and others are sutured. Most often, I've noticed lately, though, they aren't sutured in as much anymore. Usually they're in from 5 to 2 weeks, and either they're removed by the surgeon or they fall out or get pulled out. If the stents slip into the pouching system, it is not uncommon, and just to assure your patient that that's normal and not to be concerned, because that is what they want. Moving along to stoma types. So the end stoma is when a patient is has a permanent ostomy. So they usually create this, they'll pull it through, there's one lumen, they fold it back and it's permanent. So usually the rectum's removed and they're sutured and it's permanent forever. The loop stoma could be permanent, but often is made mostly for bowel rest. So one piece of bowel's pulled through the skin like a U, and they create two lumens, and one lumen is for the mucus and one is for the effluent or stool to come out. And they do this to help with bowel disease or cancer surgeries, and then they can reverse them later on down the road if need be. With the double barrel, it's similar to the loop, except that both it's completely separated and they bring both pieces of bowel through and create two different stomas. One is still mucus, one is still for the output. So when we're doing a stoma assessment and we're charting this, it's important to know what type of stoma we have. So in this picture, this is a picture of a newly created stoma. So it's important to know what type of stoma we have. If it's new, what the color is. If the color is dusky, that's not good. We want to know if there's blood flow. If it's light pink, that could be an indication that their hemoglobin's low. Temperature, if it's cool to touch, there's no blood flow to it. We want to make sure that we mention, is it moist? If it's dry, what does that mean? That means it could be that they're dehydrated. Is there a lot of height or protrusion to your stoma? Because with the farther out your stoma protrudes to a certain level, the better your output will go into the pouching system. Is the lumen located to center? Is it located at 6 o'clock or 3 o'clock? These are all very important factors when you're charting, especially for the NSWOCC or the physician or anyone to read to kind of determine problem-solving techniques. We want to always measure the size, especially when they're first operated on, because over 6 to 8 months, the stoma will reduce from the swelling. And there's a lot of edema with that, and it will eventually settle into maturity after that. And we have to continually measure after usually every 2 weeks. I like to measure just to kind of continue to adjust the sizing of the product. Which, again, here's a picture of a mature stoma, which is only after 6 to 8 weeks, which looks much better. And I like that one. It's very perfect. And of course, most importantly, when you're measuring your ostomy, that you don't have too much edge showing of skin around the edge, because what happens is, I say about a 0.1 centimeter, just a tiny bit of skin showing, because you have to leave space for your, when the bowel is, when peristalsis, when it's moving, you have to give it time to move, expand and retract, I guess is the best way to put it. And when there's too much skin showing, you run the risk of skin damage. And there's your little measuring tool. This will be your friend. So an example of some charting. This is a very unhappy stoma right now, this poor person. So the peristormal plane breakdown noted around the clock with open and moist skin. So peristomal plane with scar tissue noted towards 6 o'clock. So at the base of this photo, you can see there's some scarring. The stoma is pink and moist, which you can see, and with double lumens. So each lumen, with the double lumen, active limb noted at 9 o'clock and tipped onto the skin, lumen flush with skin, and it measures 21 millimeter. I like to say round or oval, because it's very important. If it's not perfectly round, you need to make sure that it's fit around your stoma, the right size. So if it's oval, you have to measure width and length and cut it accordingly. So I do width, and then I measure length, and then I connect the dots so that you have the right fitting, or you'll have leakage. The mucocutaneous junction is intact, which is where the skin meets the stoma, and the sutures are visible and it's producing liquid stool. So you also want to make sure that you're talking about what type of stool is coming out, if there's stool, if they haven't gone, if you haven't had a bowel movement, this particular ostomy hasn't gone in a certain amount of time. When to talk to the doctor. Are they constipated? Is there a blockage? These are all very important factors to think about. So when you're assessing your stoma, these are two examples, one of a moisture associated skin damage from leakage or wear time, and the other is for possibly changing your appliance too often, or maybe a reaction to the product, something in the product itself. So it's important to know the difference. And if you're having issues with this, you can reach out to us and we can help you with that, help you problem solve. The big question, to powder or not to powder? There's a big controversy about powder. It used to be routinely that we used the no sting powder every time we changed our appliance. And based on new best practice, we don't we only use stoma powder or barrier wipe when there's moisture associated skin damage. For me, I only use it when there's soreness. So you add a very small amount of crusting, which is where we're talking about the powder here. At the very top in that picture, that's way too much powder. And it doesn't matter if it touches your stoma, it's not going to hurt the stoma, it's okay. But if you accidentally over squeeze, that's fine, but dust it off, just like flour, dust it away. And you're going to take your barrier wipe and you're just going to either dab or squeeze it to seal that in. So it will dissolve the powder into the moist areas, and it will dry it. And then you can apply your appliance or wafer over top. You can't just do powder. You have to either, we call it crusting. So either it's powder with the barrier or nothing. But you usually don't use this unless there's a reason. If the skin is clear, the products are designed to be put right onto the skin, and you don't need to add anything else, and less is best. Less is best. And here we are with hundreds of different options of products out there, and it's very, very overwhelming for people to choose. So that's where we come in. So when they're an established ostomy, and there's lots of people out there that have their ostomy, I've just met 30 years, and a 90-year-old lady I met, she came into me and she was using the product she had from long, long ago, and she was having issues and always had, and just lived that way. And which is sad, but we worked together and we found something that worked better for her. And she was very happy. And a lot of it is some people lose weight and they need, there's a lot of skin folds. So we have to factor in something with maybe a little more of a convexity, which is more of a bowl-like base that can help with bending. Sometimes you might need to use a ring, the little rings, or some paste, or different things to help bridge the dam, as I call it. And so it's very important that we have the right products, and everybody's stoma is different. It's almost like a fingerprint. Every stoma seems to be a little bit variant of something else. Even though it's all similar, it's different. And routine care. So it's always good when if you're working with a post-op, to go in and encourage them to get everything together, and just for yourself, gather all of the things you're going to need. Number one thing, we don't use soap around a stoma. We do not use lotion around a stoma. We do not use wipes, no wipes. no to wipes, because there's chemicals that come off of this and it can cause your appliance to fall off. It can cause irritation under the skin. So it's important to just use warm water and a cleaning towel. You can use some toilet paper, tissue. There is, what else? We're gonna get our scissors and wafers and pouches, and some people still use clamps. So just prepare yourself, and I find everything goes better. I even get a garbage bag and get them to tuck it into their waistband if they have an ileostomy, just so it drips into the bag so they're not in a hurry and a panic and they cut it wrong. But even if it's an established stoma, to pre-cut your flange or your wafer first, so you're not doing it while you're standing there all exposed. But it's hard to think of that stuff. And remember to close the bag, the pouch. Man, it's like the signature mistake, a rookie mistake. I've done it many times. So tips and tricks. So what is considered a leak? Most of us, and I know I thought a leak was when it just blew right off. And that was a leak. I didn't realize until learning further that a leak is when it could be from if you're wearing your product too long. And even though there's no stool or urine on your skin, if you wear your product too long, the moisture, because of the product is made to wick off the moisture from your skin and from the product to protect the skin around your stoma. If you wear it too long, you can get moisture associated skin damage. So with a urostomy or an ileostomy, your wear time should only be 3 to 4 days, and because it's way more moist. Whereas a colostomy, based on where it's at, I guess, is way more dry. So there's less moisture. And if you're a sweaty person too, you have to factor in these things as well. Some people have they're quite warm like me. You may have to change it more often. So when you remove your flange and you look at the back of that, it's hard to see in this photo, but it's very puffy and very soft, and you can tell that it's been worn too long. And you can tell on the skin that you'll see a lot of some dermatitis there often. The next one is more about cutting the hole too large. So if you're cutting around the stoma too large, you might be measuring it too big, or it has shrunken, because some people have not come back and gotten measured or measured themselves after they were discharged from hospital. There's a lot of things to factor in. So it's good when you, even with a established stoma, to measure the stoma. That's what I do when they first come in, just so that I know that it's the right size, because they may not be using the right one. And you can often tell just by looking at the product. So the next photo is pancaking under, and that's more about maybe it's not enough of a protrusion for the stoma. They may have a flat stoma like here. And then some people have a retracted stoma, which kind of dips in, and that's when you have to bring in convexity. Often soft convexity is really good. But new best practice is that they like to use soft convexity right in the OR, the surgeons. We're working on bringing that to our hospital, and it will help protrude and establish the stoma, and it will reduce many more leaks, and it's really beneficial for the patient in the long run. And of course, warming. We don't want our stoma to ever look this way when we warm it. Some people like to use hair dryers, I found out, and microwaves. So it's really good if you pre-warm your appliance, so you can put it under your arm or under your leg. I know, your buns. If you want to sit on it, that's great. But some people have said, oh, I just throw it in the microwave, but that people can't feel, so their stoma has no feeling. And when you apply something that hot, you can burn it without knowing, and then you're just going to be in a big mess. So sometimes I say a nice little warm magic bag or a warm blanket in the hospital, and it'll just, for 5 minutes, or even just your hand, it'll warm it and it'll help adhere to your skin, which is great. Very helpful. And I think we've all had this individual in our life, just with putting IVs in and trying to get a tegaderm stuck. Fur. So some people are a little more hairy than others. This poor individual's quite hairy. So what we suggest with ostomies is to use a trimmer, like a body trimmer, and we don't use a razor. And often you can take a little bit of stoma powder and just apply it over the skin and then shave, because it'll reduce folliculitis, because we don't really want to add any irritants under the products. And sometimes, and it's really painful when you're trying to pull it off, but if you have hair as bad as this individual does, nothing's going to stick to that, and it's going to be a disaster. So it's important to do some trim, and usually I do it every time I change them, or they change them. I'm encouraging them, actually, to be fair. So how do we support our ostomy? I think it's important for everyone to know that it's good to acknowledge their grief. And what I've learned from this whole journey I'm on with these patients, and I didn't realize it from the floor nursing perspective, is how traumatic this is for people. We get a lot of people who are crying, they don't want to look. No, I can't do this, and you're like, oh man, I just got to get this emptied and I'll just do it, and it's important to understand and support them and just validate their feelings and just say, yes, I can't, this is hard. How are you doing? How are you feeling? And I know we don't all have a lot of time for that, but it's very important. And just being kind and just letting them talk is all right. And if they can't look at it today, then sometimes I go, okay, I'm going to take it off. We're going to do 1, 2, 3, let's look. And we just do a quick look and we just work our way through it. And it's just really important to respect. And some people never accept an ostomy. Some people will always need to go to a home and have someone else, or their husband or their wife or their son or daughter does it for them. And everyone has their own journey and their own trauma, and we just really need to respect and understand that. Because when we do that, we have positive outcomes. And I just wanted to mention too, because people will ask, that ostomy appliances now are designed for everyday life. People can swim and bath and shower, and they can just be dried off because the products are made for everyday living to support people. And so they can do sports, they can have a normal life with an ostomy. So when you're in the nursing home and somebody has to only get their ostomy changed on bath day, you don't necessarily have to do that anymore. I was thinking, man, I could have been showering them more often, because we always, we got to do the ostomy change on bath day. Not necessarily, or maybe it's just a shower. You don't have to wait. They could have a couple of showers a week, although probably that makes more work for everybody, but just something to know. And it's just been a really eye-opening journey for me, and I really appreciate you all listening to me today, and that's really all I have to say.
Wow. First, I want to ask if anybody has any questions, because I want to, so I'm trying not to say anything. I do want to say, I mean, I was emotional when Nancy had her video, but everybody knows I have someone very close to me in my life that has an ostomy. So it means a lot that she's presenting today. And she is officially the first SWAN presenting nationally at a conference. Not just the first one. I wanted to say it before, and Mary's like, don't say it before. Don't say it before she goes up. But we want to thank you very much. Is there questions? Any questions in person?
We have questions online.
Okay.
I'm starting with those this time, guys.
Stinkers.
So our first question is from Kim. What would you recommend to protect lesions under the flange from bulbous pemphigoid skin condition?
Lesions, you meaning like
an open wound. So bulbous pemphigoid is like a skin.
Yeah, so we often use We use Duoderm often to protect the skin. Sometimes we use antimicrobial products. Usually you would consult an NSWOCC and they would, or SWAN. It depends on how complex the stoma or the wound is, who you would reach out to. And what I usually do with Mary, where in Fredericton, is if I find something that's a bit more complex, I just reach out to her and we work together and she kind of establishes a plan. But we would use something like that underneath where we've put different types, antimicrobial stuff underneath. And then we use a Duoderm over top. And then you can apply your product over top of that and that will prevent leakage. Sometimes I even use a ring to kind of seal it in, just to reinforce or you'll leak.
That was an excellent answer. Because it's really, it's basic, like all the wound principles apply, right? So you want to donate, address the moisture issue. And there's lots of products on the market, all of who are here today that we can help. And then a hydrocolloid on top. Yeah, absolutely. And then addressing the cause of the wound. So bullous pemphigoid, I always say it wrong. Definitely dermatology would need to be involved in that as well. Yeah.
Because there are medications that can be used to treat that condition.
That's why I have an NSWOCC.
We have another question online, just because we have. What is your opinion on using milk of magnesia on moisture-associated skin damage to peristoma? Is this considered best practice? Is Cavalon Advanced a good product to use instead of the powder?
Milk of magnesia, I don't know about that. How about you?
It's an older process, and I'm not saying that it's something wrong to use. And what I'll often say with some of the older processes is if you're not having any stoma, peristomal leakage issues, then okay, maybe. But again, less is more. Cavalon Advanced is kind of an augmented type of barrier. And so sometimes we do use that in severe cases, but it's generally at the discretion of the NSWOCC or if SWAN, right? And so I do have a couple patients with jejunostomies, very high output. And so we do have that as something in their go-to kit that they've, been approved for in terms of coverage. But again, less is more. And a lot of these barriers now, I know our ostomy companies that are here today, less is more. So really, number one is addressing the cause of the leakage. There was research done out west, I think a group of NSWOCCs, there was a poster presentation, and really they addressed the cause of the leakage. No crusting was done at all and the skin healed, right? So really, it's always addressing the cause, which is what we do as NSWOCCs and SWANs, right? So, right, good. Yeah.
Good. I have two more, but I'm going to go to the room first.
Can you share a tip that we've learned recently about when you have a stoma that's, say, tipping at 9 o'clock?
Oh, yes. My favorite new trick. So this is a trick that I had just learned and I love it. And it's going to save your life in the middle of the night, let me tell you. So if you have the lumen is located, did you say 9 o'clock? So at 9 o'clock, 9 o'clock, my way, your way is not. Instead of putting a ring at the 9 o'clock to block it, you're going to put it at the opposite at 3 o'clock because it's going to bring the mouth back to center. So when you apply when you apply your product, there's going to be double pressure on this side. So it will bring the mouth of that back open and it will center it. So it will go down into the pouching system. Do you know what I mean? Mm-hmm. So some people even may need a ring all the way around. I've dealt with that because it's quite flat. So you would have soft convex. I may have needed to add the ring and then I would add another little piece on the top at the opposite and it will bring the mouth over and then protrude the stoma out further. And then it will drop down. Yeah. So, yeah, it's opposite. When I always did it wrong. And then I learned that and I'm like, I could have used this 30 years ago. So many issues. So, and it just, when you get it sealed and they aren't having all these leaks, people are so happy, and that's what makes the difference is when people are happy and they can live their life and know they can go to the grocery store without it running down their leg. The other thing in New Brunswick, I just want to mention, there is no funding in our province for ostomy appliances. So people have to pay out of pocket if they have no insurance. So if you have a big leak and you have a bad stoma, I call it bad stoma, I don't tell them that, a difficult stoma, and they're going through it. People are coming in with towels down their pants. They're crying. There's senior ladies and gentlemen out there that are going without food and trying to coach their system, and it's just heartbreaking. So we all need to work together to push for some support and funding for these people, because it's really tough for them out there. And we try our best to support them.
Just going back to the bit about milk, milk magnesia and everything
Yeah,
Denise said
yeah.
was true. But keep in mind too, the cost of all these wonderful products we can get.
Yeah.
If you have a patient coming in that's using milk magnesia or Malox, which is an antacid which will help the skin, if it's working, don't fix it.
Yeah.
If the family's using it, it's working for them. I always remember a family that was using burnt flour for a diaper dermatitis. And I just sort of said, oh, don't tell me about it, because that's a food product, but it worked. So I'm not going to tell her not to do it. So always consider where your patient is at financially and the availability of things.
That was Gail, retired IWK NSWOCC, just giving her a shout out. My son's NSWOCC when we moved here too.
She's the goat. Is that what you're saying? She's the goat.
Oh, she's a wealth of knowledge. Oh, we have one more question.
I just didn't understand. I have hearing deficit, and I just didn't hear what you were saying about what you use for products. I didn't hear all of it. I'm like a macerated skin and peristomal skin.
Oh, you mean for when you're crusting? Is that what you meant? Like,
No, when it's irritated.
yeah. So what I said was you can take the stoma powder, you can apply it to the macerated skin, dust off the excess, and you're going to take a barrier wipe and you're going to either squeeze it on or dab it on, because rubbing, A, is going to be painful, and B, it just moves the powder. So it will dissolve the powder into the wound and it will dry, and then you can apply your product right over top. And often when you change it the next time, it often will be cleared up. It heals it quite quickly.
But what type of product put over that? That's what I mean. I know the hyper,
The crusting.
Is there anything else that?
Well, if it's an actual wound where it's denuded and it goes down, so there's like a bit of an ulceration there, you would use an antimicrobial, and then I would put a hydrocolloid over top, and then I would put my product over that. Yeah. So like a Duoderm. Yeah. And so often I'll use a ring to kind of seal it, because sometimes it'll leak underneath, I found. So I might use another ring just because of there being a wound there, and it helps to seal it a little better. But the products now, really, you don't need that. You can just use the products they have because they stick really well. Yeah.
Put the ring over the stoma powder, and you dab your white, and then put the ring over that. Is that what you're saying?
No, if I crusted and then maybe there was a wound and I had to add a dressing to it, then I would cover it. And I tend to sometimes use one if it was a leak, if it was really flat, because sometimes that's the ones that are like that, the stoma. But most of the time I just use the regular product and put it over top. Yeah.
And it would probably be a good opportunity. I mean, we have some things to go through about availability to the general public, but if ever really in most areas, it's different with wound care, but for ostomy referral, you don't really need a doctor's order. I know we don't function that way. I know a lot of NSWOCs do, are the same as well. So you can go to nswoccanada.ca or nswoc.ca or ostomycanada.ca, and there's a find an NSWOC option. And so you can find NSWOCs in your area and then contact and ask about a referral, because the goal would be to never have someone come into emerge with an ostomy, because most people would not know what to do. And yeah, so that's the biggest thing as well, right? These are not problems that you necessarily need to deal with on your own. Reach out, right? Because if ongoing, you have to address the fit of the appliance, right? So that's why some people will do crusting over and over, and they're really not addressing the cause, right? So that's why I talk about if you don't even crust and you address the cause, then the problem will go away, right? So that's the big thing, is reaching out for support, okay?
Yeah, you can self-refer in the community too. Yeah.
Any other questions? No, that's okay. I think we're done. And are we at lunch now? I feel like I'm lost without the agenda. It's like right there and I don't want to walk out. I want to thank you very much for Swan in Canada presenting at a conference. She did a great job. And so we have lunch now. I'm going to announce our next presenter, who is someone I've known for a long time as well. And again, I'm always a big baby and cry very easily, but I just, Emily's an NSWOC at the IWK in Halifax, was a nurse to my son several times over the years prior to becoming an NSWOC. And so we are so happy to have her on the East Coast with us, and always reaching out to her, connecting with her, sometimes too much maybe, or giving us a lot of help in caring for our little ones, right? And so she has a lot to offer us, and we love how involved she is with NSWOC Canada. And so you graduated in 2017, and I'm going to say it wrong, your pediatric community of practice core program leader, okay, currently for NSWOC Canada. So if you look up on the website, you will see her there. And so she guides all best practice. We have a lot of best practice guidelines on the website that will kind of show you how to look at that later. But yeah, so she's at the helm of all that. So Emily, everyone.
I'm obviously not as tall as you, as I'm like, come on down. All right, so while everyone's eating lunch, let's talk about poop. Sound good? Good thing we're all nurses. This is what we do, right? So my name's Emily. I'm one of the NSWOCs. There's two of us at the IWK. We both really like to talk about poop. We have kind of a unique position in that we actually do all three tri-specialties. So we are wound, ostomy, and continence, but our continence tends to be bowel management versus urinary incontinence that you're probably used to seeing. So when Denise asked me to speak today, I was like, do you know what? Let's talk about poop. I do like to talk about poop. Last year I did kind of a pediatrics 101, what's different in pediatrics. So if we have time for questions, if you have any kind of general pediatric questions, I would be happy to answer those as well. But I'm going to talk about poop. So our bowel management program is primarily linked with general surgery. So that's our Hirschsprungs, anorectal malformations, anal fistulas, collaceal anomalies, and then we have our neurogenic bowels. So spinal cord injuries, spina bifida, and we also will take on the severe functional constipation. So I'm not talking about someone who hasn't pooped this week or this, the last couple weeks. These are the patients that have been constipated since they were born or for the last few years that really struggle. And a lot of times that's linked with ADHD or ASD, that brain to bowel barrier that doesn't connect well. And some connective tissue disorders are linked with that as well. So just a little background. Hirschsprung's disease, if you are not familiar, is the lack of ganglion cells. A typical Hirschsprung's is about 10 centimeters of the rectum, so from the anus up. It can be longer segment or shorter segment, but your typical is about 10 centimeters. If there's no ganglion cells, those are the ones that allow the bowel to open and rest open for the poop to go through. If there's no ganglion cells, it rests completely shut. So these babies tend not to poop within the first few days of life. They get really distended. And then we actually usually do irrigations unless it's really bad. So we're able to irrigate that poop out without putting a stoma in. Some end up with a stoma. This is a really busy slide for anorectal malformations. Basically, what I want you to know is that means that there is a malformation between the anus and the rectum. How surprising. So somewhere along the way, it doesn't form properly. Sometimes there's a fistula into the bladder, into the vagina. The anus isn't in the right place. It's too forward. It's too small. But all of these patients tend to struggle and need some surgical repair. And then functional constipation. So our severe functional constipation patients. This is a super busy slide. This is the Rome 4 criteria. You don't even have to read this. What I want you to know is that this is a diagnosis. This is not a side effect. This is not a complication. We sometimes are not looking for, we try to rule out all the other things, but sometimes it's just functional constipation, their anatomy, their body. It's not an underlying something else. We rule those things out, and then that's what their diagnosis is. So it is indeed a diagnosis. When we're talking about our complications of constipation, typical things, abdominal pain, decreased appetite, sleep changes and behavior changes. Sometimes in kids, that's the first thing parents will notice is their behaviors start to go downhill when they're getting constipated, and that's how they know. And then there's the megacolon. So these slides are stolen right from, my mother was an NSWOCC before me, and she made some of these slides. So was watching my presentation and said, oh, I did that. Whenever I'm teaching parents, I talk about the balloon. So if you have a balloon and you blow it up and you let the air out, does the balloon go back to normal? It usually does, I think. You blow it up, you let it right out, it goes back to normal pretty quick, right? If you blow it up and tie it off and put it in the corner of your living room and then untie it and let it out, does it go back to normal? Then it looks really floppy and big like this. So your rectum, if you have a normal poop, you have stool in your rectum, it stretches, the stretch receptors send the signal to your brain. Your brain says, hey, Emily, you probably shouldn't poop up here on the stage in front of all these people. Maybe we should wait till afterwards. So I'll wait for a toilet. And then you have to go to a toilet, send that signal back to your bowel to say, okay, I'm here. Let's relax. It's really complicated. If you have a stretched rectum that you've kept stretched for a long time, and then you let the poop out, it's still going to be big and floppy. So these kids will say they don't feel like they need to poop. And they don't, because those stretch receptors are not being activated. They'll say they don't feel the poop coming. And I'm just going to flip to the next slide for a sec. That massive amount of poop stretching the rectum will also stretch the anus open. So they leak stool without knowing that they ever leak stool. And if you're old enough to remember the Febreze commercials where you go nose blind to your own smell, they don't smell it either. They do not notice that they smell like poop. So these kids are actually having fecal incontinence incidents without ever knowing that it happened. About 50% are going to have that encoparesis, which is fecal incontinence. And then think of the psychosocial effects of that when you're at school or at university or swimming in a pool with your friends. The main thing that I want to kind of get at here is that bowel perforation and sepsis is pretty uncommon in this population. So where it's not life and death, a lot of practitioners sort of push it off. But it does have some serious effects on their life. Right. Encopresis or fecal incontinence, about 80% of fecal incontinence is related to constipation. So we will have parents all the time who come into clinic saying their kids have diarrhea. They get really annoyed with us when we say they're constipated. No, they're not. They're leaking liquid stool all the time. It's actually just liquid stool, new poop, going around that hard ball that's in there and leaking out of the anus. We also have patients who have neurologic abnormalities or some of those primary bowel problems that have had poor effects from surgery that will have fecal incontinence because their anus is constantly open or it's been damaged by surgery. So why is this a problem? We see it all the time. We have a ton of patients. Why is it a problem? We're taught from a young age that we don't talk about poop. I missed that memo. Thanks, Ma. There's no easy fix. So everyone comes to us and they want to have a pill or a surgery or something that's going to get the poop out and then everything's going to be better. It's not going to be better. Our rule of thumb is it takes half the time you've been constipated to regain the tone in your bowel. So if you've been stretched out and you clean everything out and then you keep on track, it's going to take half the time. If they are now 8 and they've been constipated since they were 2, that's 3 years of treatment No one wants to hear that, but it is a long-term problem. And every time that they hit a roadblock and get constipated after that, it sets that timeline back. They don't smell it, they don't feel it. We already talked about that. And we get them in a good place. They start having good bowel movements, and no one wants to be on bowel medication, so they go off it. And then they end up right back where they were, and we see them a lot. When we see them, the investigations that we do are really important, especially with kids. The number one thing we do to diagnose constipation in any of these populations is take a history. If they're clogging the toilet, if they're not having a bowel movement every 1 to 2 days, if it's hard and they're having rabbit pellets, that's all we need. That's all we need to diagnose. We will do an abdominal x-ray. We just have to keep in mind that that's a snapshot in time. They might have had a poop that morning and there's not a lot in there, but that's the first poop they've had in a month. So a week from now, it's going to look terrible again, right? Or maybe the opposite, that it looks terrible, but they just haven't pooped today. So we use it more as just for our treatment, what we need to do right then versus a diagnosis. We do have a handheld ultrasound, and I will explain this ultrasound. There's no baby in it. That's my tip. We have a handheld ultrasound. It's just a little handheld thing that we put on their lower abdomen, and we have it on an iPad screen and they can see it. So if you see where the line is going across, it's measuring, that's the diameter of the rectum. And we're doing a little bit of research onto what diameter actually counts as megacolon. We're theorizing that around 5 centimeters. If you're more than 5 centimeters, we're going to be doing long-term treatment. If you're less, we're probably at a less, more acute phase. I say it looks like a stormtrooper. Do you see that where the stormtrooper eyes are? That's the bladder. And you can see how the white is the stool and it's pushing up into the bladder. So these patients will also have a lot of urinary incontinence. We get a lot of patients through our urology clinic because they're having incontinence and it's actually related to constipation. The other stuff there, digital rectal exam, we never do unless it's a surgical patient and we're worried about stricture. Because kids, you ruin them and then they'll never be your friend again. If you stick a finger in their bum, they do not like you, and popsicles don't always make that better. And then the other blood work, so CF, celiac disease, and thyroid issues are kind of some of the other things that we want to rule out. So if there's any evidence of that, we would do that blood work. If there's no evidence, if it's very strongly that they're constipated, if we know that they have a surgical history, we don't bother doing any of that blood work. We just go right for what we know. So what do we do about it? This is our pyramid. This is how we kind of do our bowel management. I'm going to quickly run through some things. The whole point of my presentation today is talk a little bit about cleanses. So bear with me while I do the little bit of background, because I would be remiss if I didn't say what we did before, but I am going to focus mostly on those cleanses. So behavioral, this is the foundation. They should be sitting on the toilet with their knees slightly above their hips. Most kids will need a stool to do that. It lines everything up. If you haven't seen the Poo in You video, it's a great YouTube video that teaches kids how to do that. Sit on the toilet, take advantage of that gastrocolic reflex. So about now, when everyone's just eaten about 15 minutes ago, is the time your body says, well, we should make some room for that sandwich that you just had. So even if you don't have the feeling, that's the best time to have a bowel movement. So these kids that don't feel that they need to go, that's a good time for them to go. Sit on the toilet for 5 minutes, no distractions, no tablet on the toilet, blow on their windmill or make a snake sound that makes all those proper muscles go, and try to have a poop. Twice a day is usually what we tell them. We don't want it to become cumbersome for them. So after a big breakfast and a supper is a great time for kids who are going to school. Rewards and sticker charts are great. And we also work really strongly with psychology. We have a health psychology team that helps the families implement what we've recommended for them. Diet, dairy is constipating, bananas are constipating, all those white starches. We never tell them to cut them out. But if they're eating 6 bananas a day, maybe try just eating 1 banana, right? The thing that we're always really careful of is, show of hands here, how many people have ever been on a diet? Right? Is it easy? No. So if we're telling them that they need to change their entire diet at home with picky toddlers who only want chicken nuggets and French fries, we're going to lose the point of the medication and the other management that we need to do. So we never push it when we know that that's not going to solve their problem. It's a good foundation to have, but it's not going to solve their problem. So we don't stress changing their diet a lot. We show them what they should modify and then sort of let that go. Fiber is something that is really important. We hear about this a lot. But the main point is that you need to drink water with fiber. Otherwise, you're just bulking things up and making bricks. And if they are already very constipated, there we are. We know that they already have a lot of stool in the rectum. We don't push fiber because that just stacks bricks on bricks and there's nowhere for it to go. So we're really focusing on the management more than the fiber for that. So moving up our little pyramid here, osmotic laxatives. One of my pediatricians and I were chatting the other day, and she had heard at one of her conferences that osmotic laxatives were called mushers and our stimulants were called pushers. And now I love it and I'm going to keep that forever. And I think it'll really help the families understand. So osmotic laxatives are your mushers. If you have hard poop, PEG 3350, so that's your Restoralax, Clearlax, Miralax, whatever you want to call it. Tasteless, pretty inexpensive, softens things up. Great if they're having hard poops that we need to soften up. Not a lot of side effects. It's not actually absorbed into the system. We will use it on babies, even though that's off-label. Doesn't go anywhere. The major downfall of it is that it causes diarrhea, and if they have constipation, it's kind of what we want. There's also lactulose in this category. I don't know how many people have actually ever tasted lactulose. It's awful. So we don't use it a lot, but some patients, that's what we need it for. Moving up our ladder again are our stimulants and irritative laxatives. So these are our pushers. We have our mushers and our pushers. Senicides are the one we use the most. That's your Senocot. It comes in pills that you can crush and put through a tube or put in other things. It comes in that pill that I think we all know and love, the orange pill, 8.6 milligrams. It comes in a syrup, but it also comes in a chocolate bar. And the kids, it tastes like dollar store, like that waxy chocolate, and the kids love it. The parents have to put it up on the top shelf so they don't eat the whole thing. It's great. So when you're looking at bowel management, something that you have to like take away from the kids because they want to eat it all is fantastic. We use it a lot in our Hirschsprungs and anal rectal malformations because when they're corrected, they always have a little bit of obstruction at the bottom. So when they're younger, as they get older, they learn to push past it. Their muscles get stronger, but when they're younger, that can cause a bit of a mechanical blockage. The stimulant helps them to push past that. And then our behavioral disorders, your ADHD and ASD, they tend to hold. And if we can give them a big dose of a stimulant and get them to have one big poop that's coming out, we can clear them out and save them from being constipated or having leakage through the day. So that works really well for them. So we tend to, when they come to us, we're probably looking at a pusher instead of a musher. Biscotal or Dulcolax is another option. It only comes in a pill and a suppository, so it's kind of lame because it doesn't have a chocolate bar. But if they have poor reactions to Senna, at least we have another option. Should you do a clean out? So I almost always do a clean out for my patients before I start them on a maintenance program. If they're having accidents, you know that they're constipated enough that there's a blockage there, we need to get that out before we start anything. If we've done an ultrasound or an x-ray and we know that they're greater than 5 centimeters, again, that's our kind of hypothesis of when you get into more chronic trouble, we would do a clean out. If they're having 3 days or more in between bowel movements, clean out. Clogging the toilet, even if it's every day, but they have to, I have heard some stories, guys, like putting on gloves and taking it out of the toilet to put it in the garbage can because they can't flush it. Or I had one guy do that and then measure it in 3 dimensions for me and leave me a voicemail with the measurements. If what they're doing isn't working and we need to kind of do a hard restart, or if they're just having belly pain, you know, they don't have the appetite, we know that they're constipated, we'll do a clean out first and then get them on a maintenance program. The only time I would say I don't do a clean out is if they come in, they've already been on something, it's not quite enough. They're only having a bowel movement once every 2 days. It's, you know, not quite enough. Then we will not do a clean out, but adjust their program. Options for clean out. So what can you do to clean a patient out? PEG 3350, that's again, your Restoralax, your Clearlax. It's a great option. Your goal should be 1 dose. So 1 dose is a cap per year of age. And it takes 2 or 3 days to do that. When I'm talking to families, I say as much as they'll drink, get them to drink it. Because what's your side effect of too much? What's your overdose of PEG? Diarrhea. Oh no, that's not what we're trying to accomplish, right? Senna is a great addition to PEG, so you can do them both at the same time for a clean out. If you're doing maintenance, I don't like a musher and a pusher because you're going to mush it and then you're going to push it on, they're going to have more accidents. Pick one, whatever you think they need, and optimize it. And if that's not working, switch over. Both together gets messy. But for a clean out, again, that's what we want. Go lightly is something that we are really phasing out at our hospital. You know, the big 4-gallon jug you pull up and you clunk down and they're like, we often have to put NG tubes in to get that to go through. And it's just better if we can get them to drink something, or with the PEG, it's a little bit farther apart, so we don't have to do that to them. Pico Salix is another one we're using a lot. So this is an oral purgative that we use for colonoscopies. That kind of gets the effect of what we're doing, right? So we've started using it. You can see there we go by the guidelines on their actual website of how much to give. And it works really nicely as long as they don't have a hard blockage at the bottom. We'll try it and see if it's going to work. If it doesn't work in 2 days, we don't do it again, because if they have the blockage, it just kind of backs up behind it. It doesn't, it's a quick acting purgative. The PEG will work through and kind of break that down, but it won't, and it'll just make them feel miserable. So if after 2 days that's not working, we take a different angle for the clean out. If you're doing your clean out, you should continue all medications. My biggest pet peeve is when I go up to the floor and they're doing a clean out on somebody and they've held all of their bowel management medications. I'm like, okay, so they were on 3 caps of PEG a day when they came in, and now you're trying to do a clean out with 3 caps of PEG a day? It's probably not going to work, because that's exactly what they were on before. So make sure you're continuing what they were doing before and adding something for a clean out. If you want it to work well, put them on clear fluids. It's probably going to take a few days depending on what you're doing. PEG takes longer than Pico Salix, for example. But we don't want to stop until they have a lot of big fluffy poop come out. That's the only way I can explain it. And then their poop starts to look like pee. I cannot tell you how many times I've gone up to the floor again, and the nurse said, well, they pooped once, so we stopped it. If they are truly backed up, one poop is not going to cut it. It's more, we can hold a lot of poop. You would be surprised how much you can hold in a little body. So you want to make sure that you're actually cleaning them out and you're getting that translucent stool coming out of their bum. That's a clean out. There's pictures at the bottom. I am not a huge fan of the post clean out x-ray. If they've had a lot of poop out and you're seeing this, why are we putting them through radiation to make us feel better? You've seen it, you know we're there, so then we're going to switch to our maintenance. If all of that hasn't worked, that's when we start thinking about retrograde colon cleanses. What am I talking about? That's trendy, right? Colon cleanses. It's probably my algorithm, I'll be honest, but like on my Instagram, I get all the people in the shower with their legs up with their coffee enemas. Nobody else, just me. Okay. It's always listening. Instagram is always listening. Now it'll be on all of yours. Coffee enemas, coffee enemas. You're all going to have it. We have this cultural aversion to enemas, especially, I don't know if it's for everybody in the pediatric facility. You say enema and everyone goes, so we changed the name and we started calling it colon cleanses, and everyone feels better about it. It's amazing. Honestly, we did this about 1.5 years ago, where we were like, do you know what? Colon cleanses are trendy. Let's just start calling it colon cleanses. This is the exact same thing. If I say colon cleanse, I am talking about an enema, but the families don't freak out when we say it. They're like, okay, we're going to clean out the colon. This is great. So your initial approach is extremely important. When we go to see a patient who has been to emerge and they've held them down and shoved a fleet enema in their bum, and now we're going to say, we think you should do colon cleanses every day, they're going to be a hard no. Whereas if they've met somebody who's taken the time to show them how little the tube is, think about how big your turd is. This is a lot smaller than that. We're going to use some lubricant. It's going to feel really weird, but it doesn't hurt. This is going to help you. That approach is much better than, we're just doing it once. It's going to suck, but you'll be okay. And then we come in and say, you're actually going to do it every day. They panic about it, right? So make sure if you are someone who's doing that initially, adults are just big kids. So with your adults too, just have a gentle approach to it, that it might be something that they need going forward. A colon cleanse or a rectal enema just begins the process of breaking down, especially if they have a big fecaloma at the bottom. One enema It's not going to do it. So don't think one and done. There is no one and done in bowel management where we're talking about chronic patients like this. We also do colon cleanses for social continence. So when I'm talking about this, there's kind of two sides of this coin. So you are either doing it because you're very constipated and we're trying to clean you out with this, or you have sphincter trouble, whether you have a neurogenic bowel or you've had anorectal malformation and your sphincter is damaged and not functioning properly. And we're doing it to clean all the poop out. And I'm going to talk about it kind of one and the same because it's the exact same process, but know that there's kind of two sides to that coin, that some people are doing it every single day to clean themselves out. If they're on stimulant laxatives and we're doing the clean out version of this, they should stay on their stimulant laxatives to help push it out. If they're on a whole bunch of PEG and we're talking about retrograde colon cleanses, that's the one time where I say it's okay to hold the bowel management medications because it's not going anywhere. It's just making them feel miserable. If you're doing it for clean out, it should be daily. I've had a couple kids and like kids that are so smart that they're like, can we just do it twice and get it over with? And I'm like, yeah, sure, we can do it twice. But once or twice a day is more than enough. Everything should be baby bottle warm. So, you know, when you warm up a baby bottle and you feel it on your hand, make sure it's not too hot, but you also don't want cold. Cold will make them crampy. And they should hold it for as long as they can. Our options for cleanses, the Fleet bottle is great sometimes, and I'll talk a little bit more about that in a second. There's pediatric fleets that are 65 mils, adult fleets that are 130, and you can actually save the bottle and refill it with other things. So I'm just talking about the bottle as administering is an okay tool sometimes. We have enema bags that are already prepared with lubricant at the bottom. Again, they're okay sometimes. A lot of times we're using a Foley catheter. So we have a Foley catheter. We use the 16 French with the 30 mil balloon on it. So not a 10 mil balloon. You want at least a 30 mil balloon. And we'll use either a syringe or a gravity bag. There's also the Peristeen Plus system. I told Greg to be here and I have pictures from Coloplast and I did not put the reference at the bottom. So just, I'll tell you that they're from Coloplast and I take credit that I stole them straight from the website. So when we're talking about your enema bag or your Fleet bottle, I work with an amazing colleague, Bridget, and she always says the Fleet or the enema is like taking a shower. So you put that Fleet in, you're spraying the water in, and it's kind of going wherever and then coming right back out. If you use the Foley catheter, similarly to what you would do in a bladder, you put it in, you blow your balloon up, and then you fill it up. And it's like putting the drain in the tub and putting the water in the tub, and then you pull the drain when you're done. The Peristeen system does the exact same thing. The reason why I'm not saying it as much is I'm thinking of this in an acute care setting, and in peds, we're often doing it to the kid. They're not doing it themselves. The Peristeen system is amazing for independence for the older kids. It straps, if you've never seen it before, that Y-looking thing there with the big black ball on it, that straps to your leg. And then you can blow up the balloon yourself and pump the water in yourself. So it promotes independence. It's great for that. It's really cumbersome if you're trying to do it to somebody else and manage all that. So the Foley and the bag does it if you're doing it to somebody else. The Peristeen system is great for independence. And it's really important that they have coverage if we're talking about the Peristeen system. It ranges upwards of $2,000 for the set and then a couple $100 a month for catheters. So just keep that in mind that you want to make sure that they have the funding, the insurance for that. Otherwise, a Foley catheter and a bag, although a little bit, you know, more, I don't know, less beautiful, will still get the same effect. So these were stolen right from the Coloplast website. Thank you, Greg. You would insert your catheter about 4 to 5 inches. You want to make sure that your balloon is inside the sphincter. You don't want to blow up a balloon in the sphincter. Blow up your balloon, and then you insert your solution. So it's going and filling up that left side of the colon, and then they hold it for 10 minutes, 15 minutes if they can. And when they release the balloon, the idea is you pull that tub drain and all of the solution and stool comes out with it, and we're washing it out. So when we're doing it for a clean out, we're breaking off pieces and getting that out. When we're doing it for social continence, we're taking all the stool that's built up over the last 24 hours, washing it out, and they don't have anything to leak during the day. What do we use for solutions? Everything should always be at least room temperature. We like baby bottle warm. Some people, especially the neurogenic bowel, just need saline. They just need that conduit to pull it out. We usually start at 10 mils per kilo, and we will titrate up if we need to effect. We do use Fleet. We will use the Fleet bottle, or we will put Fleet into the syringe and use that. We use that more as sort of a rescue or an extra, maybe once a week. It can affect your electrolytes, so we don't want to be using that daily. The thing we use the most is glycerin. So we will mix it at least 50-50 with saline. I don't know if anyone's ever played with glycerin. It's really viscous. So if you try to take straight glycerin and push it through the syringe, you're going to end up wearing glycerin and probably poop too. It's not nice. It's not a good look. Trust me, I've worn it. It's not a good look. And then you can see I've put the amounts there. We start low and titrate up as we need to. We only titrate to about 60. That's not really a hard and fast number. We just find if they're using more than 60 mils of glycerin, they're getting more crampy and they're not getting an effect from it anyway. So at that point, we would add something else. And some people have a pretty adverse reaction to glycerin. It's a pretty aggressive irritant. So they'll have a vasovagal response. If they're doing it, they'll vomit, turn gray. In that case, we'll try mineral oil. I always find that word really hard to say. Mineral oil with the same mixture, the same amounts. It doesn't work quite as well, but it does tend to alleviate that vasovagal response that some people get. And soap suds, we do have a few patients that do soap sud enemas. So Castile soap, or they grate ivory soap. And that is, again, is an irritant. It's the glycerin in it that does it. So they'll use that instead. One of the biggest questions I get asked is why we are the IWK and we sedate everybody for everything. Why don't we just take them and put them to sleep and get that poop out so they can get a hard reset? One of the biggest reasons is the social expectations. We don't want patients coming every 3 months to get their, biannual clean out because they won't do any bowel management. It's a general anesthetic. We know that's not great for your system, especially repeated if you don't need it. There's a risk to the sphincter. Does anyone know how a manual disimpaction is done for a fecaloma? Anybody? We have some really large male surgeons at our hospital. So if you can picture the size of their hand, and they take that hand and they put it into the bum, and then they use their other hand and push down on the abdomen and they scoop the poop out. It's awful. It's really painful. So we don't like that. And they can only get elbow deep, which is about as much as we can get with our enema. We do it if there's a bowel obstruction, large fecaloma, or they're not responding to treatment, or if they're backing up into their kidneys. Anytime that we've done a clean out and we're doing maintenance, we make sure there's a follow-up plan. We have these nice little stoplight sheets that we've created. So basically, if things aren't going well, you're going to try this. If that's not going well, you're going to do this. And then if that's not going well, you're coming back to us. Okay, I'm moving to the top. This is our evolution of enema delivery. So we went from bullhorns to, enema catheters, colon cleanse catheters. And I just want to talk quickly about antegrade colon cleansing. So this is allowing for a washout of the entire colon. It's a little tube that's put in. I'll show you in a minute. It promotes independence. It's really easy for patients to do themselves. They don't have to try to stick something in their bum. They can pick the time and place that they're doing it. The goal is that they're washing all that stool out and they don't have anything to leak or build up for at least 24 hours. We call it social continence. They're not truly continent, but they're able to be socially continent. They're not pooping at school or in that tub or in the pool or on that sleepover with their friends. And we will do it pretty readily for neurogenic bowel, or surgical patients that are having issues, or if we have a severe functional constipation. The main thing, especially in those patients, are ASD and ADHD, they have to show that enemas are going to work. So they have to have done a colon cleanse, because this is just another way of delivering a cleanse. It's not an end-all be-all fix everything. If the enema doesn't work from the bottom, it's not going to work from the top. We have a couple ways of doing that. The first one is called a MACE, or appendicostomy. So Dr. Malone at Sick Kids, we had a Sick Kids nurse, is she gone now? In 1990, created this procedure and started doing it. He derived it from the Mitrofanoff, where they take the appendix and put it between the bladder and the umbilicus to drain urine. In this case, you take the appendix, which is hanging off the bottom of the cecum. You can see there, I blew it up a little bit for you. little finger-like projection from the end, and it's actually connected to the cecum. And they bring that out to the abdominal wall. They can either do it to the umbilicus or they do it to the right lower quadrant, and you catheterize yourself through that little conduit and drain you put in your solution, and then your stool still comes out your bum. It doesn't come out that is an what is the word? Input stoma, not an output stoma. So you put the solution in and it still comes out of your rectum. We also have had a surgeon, our surgeon that does these, she calls it the macostomy because she'll do a mace, but she still puts a tube in it just to make sure everything is easy to use, and that because some kids don't like to catheterize, so she'll put a tube right in it. The pros and cons of the MACE procedure, it's permanent. They don't have to worry about anything ever again. It's there. There's no foreign body. I say ish because we do put tubes in them sometimes. There's no change in their physical appearance, especially if it's in their umbilicus. No one can see it. It's a little kind of opening at the base and they catheterize through it. And it gives them that independence to do it themselves while they're at university or high school or on a trip. The cons are that it's permanent. So it's there. Once it's there, it's there. 30% of them stricture, so end up with a tube. So that's why I say there's no foreign body-ish. They do tend to end up with a tube in it at some point. And that in the umbilicus can be a little bit tricky because it gets a little mucky. And it's all dependent on the availability of the appendix. If they've had appendicitis or if they have a Mitrofanoff already that's used their entire appendix, they don't have that option. So then we'll go right to the next option. We do have a surgeon right now who's doing the MACE procedure, and she will do a Mitrofanoff and a MACE at the same time. So she takes the appendix and cuts the bottom half of it off and puts that between the bladder and the umbilicus. And then she pulls the other half that's still attached to the cecum up to the lower right quadrant. So that's pretty cool. I've gone to see the surgery because I'm nerdy and I think it's cool. The other way of doing it is to put in a cecostomy tube. So laparoscopically through 2 or 3 incisions so they can get their little cameras in there. They start by putting 2 to 3 big sutures between the bowel and the abdominal wall to adhere it to the wall. If you're getting patients back post-op from this, they look disgusting. They are disgusting. They look infected. They are infected because they're going through the bowel and there's poop on them. But as soon as you take them out, everything's going to be better. So I've had a couple times where family doctors won't take them out until they've treated the infection. And we're like, just take them out because it'll look better. It'll be fine. They usually stay for 2 to 4 nights. And that's more for teaching than anything. It's not a overly invasive surgery, but they need to know how to use it. We have 3 types of tubes. They're always going to get the CHATE tube first if they have this procedure. This tube has no one-way valve in it. It's low profile. They're changed yearly by interventional radiology, and interventional radiology provides the tube, so it's free to the family. And St. John, Fredericton, Charlottetown, Sydney, us, and the QE2 will all do this procedure, so they have options elsewhere. The cons are that the bottom of it can cause some leakage. There's no one-way valve, so the poop can come out through it sometimes. The adapters for them are pretty expensive and hard to get, so they get one when they're put in, but if they want a second one, it's pretty expensive. And they only come in 3 sizes. Also, if it gets pulled out, they have to go to the hospital. So they put a Foley catheter in to save the place, and then they have to go to the hospital and get it reinserted. There is a mini ACE. This is also meant for colon cleansing. It's a balloon device. They can change it at home. There's many sizes and they go up to 10 centimeters. So if you think about where that is, the abdominal wall can get pretty thick. Where our feeding tubes, we don't need to be that long because the abdominal wall tends not to be that thick there. It can get pretty thick down in the right lower quadrant. So we need longer tubes for our bigger kids. They need to be changed every 3 to 6 months, sometimes sooner. And the balloon on them is only 1.5 mils. We've had sometimes where they get pulled out more easily, even with the balloon attached, which isn't so nice. They're a bit higher profile and they are very expensive, and you can only get them from a pharmacy in Ontario. So the families order them in and then have to be reimbursed by their insurance company. This is just a little comparison on the Mini ACE website to CHATE, but you can really see the profile difference. So CHATE is a lot more low profile, but there's a lot more support at the bottom from the balloon for leakage to come out, a stool to come around the tube. And then we also use a Mickey. A Mickey is not meant for the bowel. It's meant for feeding, but we do use it. It's a balloon device. The balloon is a little bit bigger, stays in a little bit better, pretty readily available at our pharmacies so the patients can pick them up themselves, less expensive, has that one-way valve, only needs to be changed every 6 months. They do it at home. They're only available up to 5 centimeters. So we run out of room a lot of times that we can't get them big enough. And again, they're not actually meant for the colon. So if we run into issue, the company's like, you're using them for the wrong reasons. And just pros and cons to the actual cecostomy process itself. It's a fairly non-invasive surgery. It's reversible. If at some point they start stooling on their own or decide they're going to get an ostomy, we pull it out, it closes on its own, gives them that independence. The cons are that it is a foreign body, so it is a risk for hypergranulation. This is obviously a very extreme case of hypergranulation that turned into keloids. This mom will tell you she would do this procedure over and over again. It changed her life. This is not an issue for her. The stooling was so life-altering for her that she would do this procedure over and over again. It can get pulled out and have to be put back in, the tube itself. And there's a risk for peritonitis, particularly at insertion. You could accidentally perf the bowel. All right, so the tube, now what are you gonna do? I know I'm running out of time, so I'm gonna be really quick. So if you have a patient coming back to you with one of these tubes, which our patients are growing up, so you're gonna see them and they're everywhere, ha ha ha. The first 10 days, we just put 10 mils through just to keep the tube patent. After 10 days, it's almost exactly the same procedure that you would do for that retrograde colon cleanse. You put your solution into the tube, you wait about 15 minutes, and then you're going to flush a large amount of saline through to wash it out. It's like when you're Dranoing your sink, you put the Drano in, let it churn up, and then run the tap really fast to clear everything out. Do not put Drano in your patients. That's not a good idea. But the same process with your usually glycerin and saline. Then they sit on the toilet, they push everything out, clean all their supplies after they disconnect and let it air dry, and they can reuse them over and over again. We get them to do it every day until they've been clean with no leakage for 2 weeks. After that, they can start skipping a day here or there, see how it goes. And a lot of patients can get to twice every 2 days or even 3 times a week. And then just a couple of other surgical options that we offer. Botox injections. So just like if you got it in your forehead and it relaxes your muscles, we will do it in the anal sphincter to relax that anal sphincter if they're a holder. That gives us a little bit of time to work with them medically to get them stooling. Sometimes we have to do it a couple times in a row, but we can sometimes overcome holding patterns by doing those Botox injections. That manual disimpaction that we talked about, why we do and don't do it, that's considered a surgical option and higher than doing retrograde colon cleanses, enemas. So we really don't do it if we don't have to, if we can try something else. And then obviously a colostomy or an ileostomy with or without a resection is another option that we go to if this is not functioning, or if the cleanses don't work for them and we have to think about something else. All right, that's the end. This is my daughter a long time ago. She's much bigger and sassier now, but she's demonstrating perfect pooping technique. All right, I know I'm close to end of time, but maybe a question or two if there are any.
We have some questions online.
Okay.
So, thoughts on acupuncture and chiropractor for constipation in babies?
Medically and research-based, I have nothing to say, but if it makes you feel better and works sometimes, sure.
Good.
How about that? I've gone to the chiropractor. I will swear by the chiropractor, but medically speaking, there's no evidence that shows that it helps.
And would the catheter enema work with geriatrics as well?
Absolutely. There's no reason why it wouldn't. I think it's a great option. And if you think about the difference between the Foley catheter and doing a fleet, the Foley catheter is actually less risk. As long as you're making sure that balloon is above the anal sphincter, it's a lot softer. There's a lot less chance of any if you could perf a bowel with a Foley catheter, you are very talented. A fleet, I feel like that also would be really impressive, but more likely than a Foley catheter.
Any other questions?
Thank you. Wait, I have a gift. Thank you very much, Emily. I always learn from you, and I've already kind of whispered it to Kathy because as a camp nurse. So I'm an NSWOCC that goes to camp every year, volunteers at ostomy camp. We do see children, youth from all over Canada. And so I'm proud of the guidelines and this whole process you have developed, but I've just learned even just with the glycerin and some of those, the cramping or the fainting and being sick. And so we have children that come from all over Canada with all different regimes, like you name it. And so we do need to work on guidelines. And Carly and I, who is the head end camp nurse, we've reached out to a lot, but we do really need to, start pushing it more because we see all the differences nationally, and we have to standardize it somehow. So we know how to help them better. That's on our to-do list. Here's a gift for you. Thank you very much. Oh, your water too. Thank you, Emily. Okay, I'm going to switch presentations while I'm doing that because we have Marcy White coming up to present next on wound cleansing. Come on up, you can come on up. But I want to say for the vendor quest, you to be able to put your name in first, put into the draw, put your name on the sheet. Okay. And you don't have to get them on Licky or the NSWOCC Canada signature. I've had people come up to me, but make sure you put your name on it before you put it into, there's a box at the back corner, right around the corner there. There's a big box at the end of the day. Okay. I just want to make sure you guys put your name on it. Okay. So we have next Marcy, who I haven't known for very long, but has very quickly has become a good friend. And in our NSWOCC world, we tend to get very close very quickly because we all have the same mind at like addressing the cause and looking at the whole person. And there's a lot of things like that, but we all tend to love each other right away and hugs and everything. I don't know if you've noticed any of that happening today. But you've been a nurse since how long? 2009. But she did just graduate from the NSWOCC program, and she did receive her CNA certification. So we're very excited for her. And so we have the honor of her. She's in Summerside, PI. So she's one of our PIers, and she's here presenting today. So thank you. And she's already, she's going to hold this over me maybe for in the future next year. Okay, you take it away.
Yes. Okay, so I'm here. Yes, we are like a big family, so I said I would help Denise out. So I'm going to talk about wound cleansing. We're going to focus on I call them the best practice recommendations, but it's following the 2025 International Consensus document by the International Wound Infection Institute, which was titled Therapeutic Wound and Skin Cleansing, Clinical Evidence and Recommendations. It's online, and I think it's like 52 pages. So I would encourage you to look it up. I learned a lot, and I just graduated.
Would you speak a little closer?
Yeah. Okay. I just graduated, like I said, in May, and I learned stuff going through the book here in the last few weeks. So I encourage you to look it up. Defining therapeutic wound cleansing by IWII is a targeted removal of undesirable surface contaminants. So your exudate, your loose non-viable tissue, any microorganisms from previous dressings, both on the wound bed and peri-wound, using a wound cleansing solution and a mechanical action. So when I was reading that, I instantly thought of wounds that we've had come back in, and it kind of drives you crazy once you're in this position. But you get the wounds that come in with either hyperkeratosis, so you think a buildup of skin cells, or you come in like an eschar and they've been putting gel on it, and there's layers and layers of gel on that isn't cleaned off. And you'll get calls saying they needed to be debrided. They don't. They need to be cleaned off, which any nurse can do. So there's 3 elements of therapeutic wound cleansing. One is the use of a solution to clean the wound, applying the appropriate wound cleansing technique, and using the appropriate medical equipment to perform the procedure. So why do we need to do wound cleansing? We kind of already mentioned it. To remove organic and inorganic debris, the loose necrotic and non-viable tissue, your wound exudate, and reduce microbial burden. and to contribute to the hydration of the desiccated wound bed. So when non-viable tissue and your exudate and the debris all lay in your wound bed, it increases the amount of neutrophils and prolongs the inflammatory stage. Then the wound bed matrix, your MMPs or metal proteinases are then released, which stimulate the pro-inflammatory cytokines and lead to the destruction of the extracellular matrix. So this all extends the pro-inflammatory. Oh, wait, no. Yeah, reduce the chance of proliferation of microorganisms and biofilms, and then it reduces the pro-inflammatory response and it stimulates healing. So you'll have exudate and you want to get your debris off, but you also don't want your wound to be too dry. So we think when you're wound cleansing or am I hydrating, you want to keep it moist to also prevent discomfort and pain from your patients. They may be itchy and that may help. So other benefits, improve the accuracy of your assessment by your ability to see the wound bed, reduce unpleasant signs and symptoms such as odor and exudate, reduce pain and itchiness, and feelings of cleanliness and comfort. And sometimes, especially if they have wraps or casts or boots on, after you take them off and give them a good wash with soap and water, they'll say, oh, I finally feel clean after a week. So it's important to give them a nice scrub. And wound cleansing before culture and sensitivity. And it's always, do I clean before or do I not clean before? IWII supports the practice of wound cleansing prior to the culture. It reduces surface contaminants and reduces false negative results, and it enables you to see the wound better to get the best sample from your wound tissue. What areas of the wound require therapeutic cleansing? So the wound bed and wound edge, the peri-wound, and the surrounding skin. And there are 3 therapeutic cleansing zones, as you can see there. So if you think about a 30-centimeter ruler, and do we actually, when you are all cleansing, clean that far out, or at least 20 centimeters? So the first zone being the wound bed. The purpose of wound cleansing is to remove surface contaminants and promote the healthy wound bed. The wound bed is the area in red. Even if the wound bed is healthy tissue, you still need to remove the exudate and any debris that might be laying there. The next part of the same zone is the wound edge, where the wound meets the wound edge. And it's particularly susceptible to infection. So it's important to remove any buildup of keratinocytes there. If your wound bed heals in a normal trajectory, it'll normally heal from the wound edge in. However, you could have epithelial islands form from like where hair follicles would be or be within the wound bed. And due to the wound edge's direct exposure to the skin's microbiome, it also increases the risk of infection. So it's important to clean that, especially prior to debridement. It can roll or hang over, so you want to make sure that you get in underneath that wound edge. Yeah. The second zone in the teal kind of color, it extends 4 centimeters out, is your peri-wound. And it includes the skin tissue underneath the dressing. So oftentimes you'll get exudate under there, but it might also get dressing residue to remove. And it also has a higher microbial burden further out from the wound. That removes the contaminants that could migrate into the wound bed, removes moisture that can cause moisture-associated skin damage. It also removes excess proteases from exudate that can cause inflammation around the peri-wound, and your adhesive from your dressings. So you can have, whether it's the silicone or your tape, that's very important to wash off too before you're applying your next dressing. And then it allows you to see the skin, whether you have erythema or inflammation or anything like that. The surrounding skin, zone 3, is still considered part of the therapeutic wound cleansing area, and it extends 20 centimeters out. If you think about this, do you often do that? So if you had a toe wound, are you cleaning right up from the ankle bone down? If you had a lower leg wound, are you cleaning from the knee down? They in the IWI consensus document, it says the bone above your injury to wash from there down. Oftentimes, if you have, so you're trying to secure a dressing on the bottom of a foot, you might have it wrapped in gauze that's on there for 3 to 4 days, 5 days. So that's not getting cleansed. If you have compression wraps or the air boot or things like that on, it's important to wash that whole area, even if the wound is on the foot. So wash right from the knee down. Considerations for wound cleansing. So there's not one size fits all approach. You got to consider your dressing procedure. So your type of aseptic technique, your cleansing technique, and your cleansing solution you're going to use. There are 2 standard techniques for cleaning. Your sterile surgical technique, and which is using sterile equipment, sterile solutions. And then your other technique is just your clean technique. So if you can't be in a sterile setting like an OR suite, you're in a room that has contaminants, you'll use clean gloves, clean equipment. Factors to consider when deciding on the type of cleaning technique is where the patient is, the patient's immune status, the size and location of the wound, the extent or visualization of the wound bed, and the goals of your care. The types of wound cleansing solutions, and this is still a learning thing for me. There's a lot of cleansers out there. So inert non-sterile solutions is, for example, potable tap water, are those with no active chemical ingredients in them. So they don't have anything to help loosen any tissue or non-viable tissue or debris. They're generally not appropriate for wounds with infection or heavy amounts of debris. They could be used on wounds with no infection. IWII has outlined the following suggestions when using non-sterile potable water. So ensure it's potable. And what does that mean? That we can drink it. If it's coming from the tap, let your tap water run for 2 to 5 minutes because there could be contaminants within the pipes of your plumbing. That's it. Do not use from a stagnant source. And if you're using potable water, then you want to boil it, let it cool, and just have it lukewarm. There's also traditionally normal saline is used, and normal saline is the preferred solution because it's inert and it doesn't hurt the wound bed. It's non-cytotoxic, cost-effective, and sterile. Sterile saline is also used, but it's more, you'd use it more to clean like the peri-wound area maybe. And then you also have your surfactants, which are next. Oh, I wanted to mention shower. So we do get into surgical incisions. Should they shower? Should they not? Sometimes it's a surgeon's preference. Depends on where it is, the sutures, how the wound is. Is it dehisced at any place? So you'll have to there's many factors to consider if they should be in the shower or not. The complexity of the wound. So another type of cleanser is your surfactant. So cleansers with surfactants they have chemical properties to enhance the solution. to reduce the tenacity of the debris in the wound. So it's a substance that's added to the cleansing solution to reduce surface tension. So it just makes it spread when you put it on, spread it across the entire wound bed. It better penetrates the wound, and it does help stimulate autolytic debridement. It does impede microbes' ability to attach to the wound bed, so it reduces their ability to produce biofilm. And when it mixes with debris, it does loosen the tissue. It makes it more easier to remove. Antiseptics are antimicrobial solutions and used to prevent or used to cleanse wounds that are showing signs of infection or biofilm. And they can cover bacteria, fungi, viruses, protozoa, and you can also use a combination of antiseptics and surfactants. So factors to consider when choosing a solution: the type of dressing you're going to use and your cleansing technique, the characteristics of the wound, the presence of infection, the presence of your microorganisms, if there is any, your patient's goals, cytotoxicity, pH and allergenicity, and local policy and procedures at your facility. Therapeutic index. So a higher index indicates a safer wound cleanser with a greater clinical effectiveness. And the pH of your wound and the pH of your cleanser. So skin has a pH range from 4 to 5.5. pH of wounds varies from acute and chronic wounds is greater than 7. Chronic wounds may have a higher pH of 7.4 to 8.9 compared to acute at 7.4. So then alkaline environment is maintained until the reepithelialization occurs from the edge of the wound bed in when the stratum corneum returns, which is then 4 to 5.5. So I don't use them. Do you guys use pH test strips or anything? No. So you can have pH test strips to check the pH of a wound, and you could pick your solution to match the pH of your wound, but I've never used them. Factors to consider when choosing a cleanser. The temperature of the wound cleanser is important. It should be the same as the body temperature at 37 degrees. If the wound bed temperature falls below 33 degrees, the cell mitotic activity is impeded and disrupts wound healing. And strategies to maintain optimal wound bed temperature. So the length of time that you have taken to do the procedure, reduce the frequency of the dressing changes, and using a solution that has been warmed to body temperature. But IWII did state be very careful of warming solutions that should only be body temperature. Don't warm anything in a microwave. You can get hot spots and cause burns. And then be aware of excipients, and that's inactive substances that are added to cleansing solutions for reasons such as stabilizing, longer shelf life, and they can become irritants to some patients too. So what type of solution should be used for therapeutic skin and cleansing? We want to be sure to take care to cleanse all the debris, all the hyperkeratosis, so that the built up skin cells and dressing residue. You want to use a mild soap with a pH same as the skin, and something to clean the peri-wound so you can assess the wound bed and peri-wound for any maceration or erythema, edema. A wound cleansing technique refers to how the wound cleansing solution is applied in order to provide therapeutic wound cleansing. So techniques vary in how vigorously one cleanses a wound. And I notice oftentimes when you start out, you're more timid to hurt the patient. So it varies in the amount of mechanical force used. For easily healing wounds, you don't have to use much vigor. You can gently cleanse, but for harder, more chronic wounds, you may have that biofilm forming and more devitalized tissue, so you might need a more vigorous cleaning. And factors to consider when choosing a wound cleansing technique: the moisture balance or moisture enhancing technique versus preventing maceration and protecting the peri-wound, the condition of the surrounding skin, so if it's rashy, dry, or scaly, and the patient preference, their pain tolerance, and the amount of force you'll have to use. So wound cleansing techniques. There's many. When I read this, I realized I have to change some of my wording, especially when I'm charting. Irrigating and flushing, so is providing a continuous stream of cleansing solution to the recommended pressure, which is 8 to 15 PSI. This helps loosen and remove debris and microbes, and it doesn't damage tissues. You can achieve this by using a 35 ml syringe and a 19 gauge cannula for the appropriate pressure. You can use light irrigation like water from a trap or an aerosol spray also to clean a wound. That's not the preferred method of cleaning though. Soaks and wet packing is when you saturate gauze or cloth, highly saturate them in a lukewarm cleansing solution and place them over the wound bed in layers and let it soak for 3 to 5 minutes. Traditionally, the article said that they used to, years ago, soak for at least 20 minutes, but now it's 3 to 5, most of them. Check your solution insert package to be sure, but a lot of them are 3 to 5 minutes, and that helps loosen debris and hydrate the wound. So a compress is used to remove excess moisture and surface debris by way of the astringent properties of the wound cleanser. So it's used to reduce trauma and discomfort on a healthy wound bed. You layer the cloths and they're soaked in lukewarm cleanser, then wrung out, and it essentially removes the exudate or wetness from the wound until the saturation point of the cloth is reached. So I have been writing compress of such and such in my chart, but it's actually a soak that I want. Swabbing, you might think, oh, she wants a swab to be send like a CNS. But swabbing in this consensus is cleaning with a gauze or a cloth, soaked with your wound cleanser, and then wiping the exudate, debris, and non-viable tissue from the wound bed or peri-wound. Useful for more vigorous mechanical force, and there is risk of damaging your healthy granulation tissue, so you have to be aware of that, and the pain or discomfort that it could cause the patient, so just be aware of that. Scrubbing, cleansing, pad, monofilament or microfiber pad. This is a more vigorous, it uses a more vigorous mechanical action. There are specially designed pads, and on the pads, they kind of have monofilaments that'll work to agitate debris and pick them up from the wound bed. Debridement pad, the primary use is cleansing the wound bed, improving visualization in preparation for debridement or topical therapies to stimulate healing. And studies have shown that it doesn't cause damage to granulation tissue, and there's less pain and discomfort over other techniques. Installation and dwell and negative pressure therapy. Got to do this for the first time in the last, 2 weeks? Denise got some calls on that too. So it's when you use a wound cleanser and instill into a machine using negative pressure. So it automatically provides wound cleansing. It removes the wound exudate and debris from the wound bed, and it shows a much shorter time to wound healing. It's appropriate for certain types of wounds. Inpatient settings are most common, and it does require specific equipment. Generally recommended for negative pressure to do the suction part over 2 to 2.5 hours, usually, or sometimes 3, and pressure set at 125, depending on where the injury is or the wound, and a dwell time of 10 minutes. Hydro-responsive dressings. It's a combination of a wound cleansing dressing. It promotes wound cleansing by delivering or removing moisture to the wound bed. And depending on the moisture balance of the wound, it contains ringers and an absorptive material to balance the wound. And it does soften non-viable tissue. It does show good results at reducing infection and wound size and improving wound tissue. The IWII consensus document includes a table with indications for use for each of these dressings at the end. I think it's at the end of explaining all these. And there's a few other tables in there. So I really, really encourage you to go to the document and look it up. Wound cleansing sequence. So you want to reduce contamination, reduce microbial burden, and prevent formation of biofilms. The naked eye is not always able to identify the area with the highest microbial count or where the biofilm exists. So there's always or I've heard it being debated, do you clean from the inside out or the outside in? And where does the higher microbial burden lie? So this leads to, it's been shown that the peri wounds frequently contains higher bacteria loads, particularly with undermining, but you can see on your wound bed in these recommendations where your higher amounts of debris are if you clean it well. And then they also are mention or recommend fluorescent imaging. And it's an emerging option that provides real-time imaging to guide wound cleansing. And this helps show the type of bacteria in the wound, the location with higher concentrations, gram-negative, gram-positive, aerobic and anaerobic organisms. It does have its limitations. The bacteria can be missed in the presence of blood, can be deep in the wound, and so can be missed. And you may pick up other things like sheets, tattoos on people, or dye, especially helpful in wounds that have been stagnant for a long time. And it just guides you to where you should clean more if you wanted to. If you have these patients that don't want you to clean their wound, it just hurts too much. If you can, we have one of them and I don't use it enough. But if you can take a picture of your wound and show them where it has different colors for different types of organisms in the wound bed. So if you can show them, here's, a higher microbial count, I need to clean that off, and take a picture after is the recommendation, and show the patient, then you might be able to sell the wound cleansing to the patient better. Pain associated with wound cleansing. So you should always assess the patient's severity, quality, and characteristics of pain using a validated pain assessment tool, and 3 A's of pain: anticipate, administer, and assess. So how to adjust procedural wound cleansing strategies: adjust your therapeutic technique, whether it be gentle technique by soaking or compresses or using more mechanical forces. Manage their symptoms causing pain, the inflammation or infection. Choose a wound cleanser that doesn't cause discomfort. Warm your wound cleanser to body temperature, and maintain the moisture balance in the wound bed and peri-wound. You can use non-pharmacological or adjuvant therapies. So individualized patient care, assess the patient's triggers and stressors, and develop a plan that works for them. You can use relaxation techniques, music therapy, distraction techniques, etc. Explain the procedure before starting it with the patient. If they're anxious, that's going to help. Educate them. Give the patient notice before you're going to start, and just instead of going in and removing the dressing and getting at it. And refer to who you need to refer to, whether you need a pain specialist or a psychologist to help them get through. So pharmacological pain management, you can look at giving medication to help if needed, and give it early enough. Give it time to work before you actually start the procedure. You can consider topical anesthetic or anti-inflammatory preparations, and discuss the appropriate dosing with pharmacy. And consider antimicrobial stewardship when using cleansers. It's a lot less apt to build a microbial resistance using an antimicrobial cleanser, but still be judicious in use. Ensure appropriate use for infection control procedures, advocate for the ability of a variety of cleansers, monitor and evaluate use of antiseptics, educate patients and families, and avoid prophylactic use. So if you don't need it, if there's no signs or symptoms of infection, you can get away with the normal saline instead of using your antiseptic or soap and water. And that's it. Thank you.
We have an online question.
Yep.
I have read conflicting evidence around distance for irrigation. Have you encountered any direction in this, and are the guidelines advising soaking over irrigation?
Direction of what?
Encountered any direction on irrigating distance away from the wound? No. And are the guidelines advising soaking over an irrigation?
Irrigation, they mentioned being less favorable, I would say, over wound soaking, because you get that, if you're using antiseptic with a nice soak, you're having that time to loosen any non-viable tissue and debris, and then you can clean it off after. With your irrigation, you're just going to be flushing it in and with irrigation pulling it out. So in the IWII guidelines, it said irrigation was the least favorable.
Well, and I think a good comment is after soaks or compresses is cleansing the wound then again, right? Like that's the biggest thing sometimes,
And do your soak and then cleanse. Don't
Yeah.
cleanse and then do your soak.
yeah, and then removing the old wound product too, right? So how many times do we go in and there's still, if it's a paste or something we're using and it's still laying in the wound, and then they're putting the soak on and really, so yeah, it's just about cleaning the old wound product out, soak, cleansing the wound, right?
Yeah.
Yeah.
Hello, what is the best practice for a wound culture?
For obtaining a wound culture?
Yeah.
Cleansing your wound beforehand, but just using like normal saline. Don't use, say, hypochlorous acid or anything like that, because you're affecting the microbial.
Speak into the mic, please, so the virtual can hear you.
When you go to get a culture, like a swab for culture, you clean before you obtain your swab, but just use normal saline. Like stay clear of cleaning with antiseptics or anything like that to affect the microbial count on the wound bed. And then can you? Okay. Okay. And then the technique for doing a swab, the Levine technique. Yeah. So you put it on the wound bed and then turn it. Yeah. Yeah. Yeah.
So they're saying on, or in the crowd
Healthy
that you're
tissue.
supposed to do it on healthy tissue.
Yeah.
Okay. The red one, yeah.
What you say, the red one?
Well, yeah, because we've had this before. I've even had discussions with doctors, like, shouldn't we be taking a swab from the yellow slough? And no, that's not the case. You want, and if, yeah, we'll often do a soak, cleanse the wound, and then you're going to cleanse with some normal saline and then take your sample. Is it Levine or Levine? I never know, but Levine, yeah. Yeah.
Any other questions?
Good question, though. That was a good question. Thank you very much, Marcy, for doing this. We appreciate you. Hi to everybody online too. I want to thank you for attending virtually. This is our last session of the day. We saved the best for last. Natalie? No? Yeah? Everybody, all the other presenters are going to be mad at me now. Nancy? No, Nancy's not mad. We agree, yeah. I'm excited for this presentation because I know I'm going to learn a lot. Nathalie Gaudin is an NSWOCC at the George Dumont Hospital in Moncton. We work closely together because a lot of our patients go back and forth. In New Brunswick, we have two health authorities, Horizon and Vitalité. Some say it's French English, although we speak both at both. But in Moncton, we're unique because we have both health authorities. We have 2 hospitals here in Moncton. And so we do literally have patients that go back and forth. We do on chemotherapy in the Moncton Hospital at Vitalité. They do radiation. They also do dialysis. We do dialysis if they're in the ICUs, but they go back and forth. So often we're coordinating and helping each other with some of our complex cases. But she has a big history. I'm trying to, this is blurry. Oh my goodness. She's, you've been a nurse for 25 years? 25 years, 28. She started in oncology. So she has a big oncology background. And so this is why this is an area that she's quite passionate about. And so I'm excited to learn about this well, because there's all different types of wounds. Radiodermatitis is one that happens as a result of radiation. And then we have our oncology, most commonly are malignant wounds, right? Which are non-healable wounds and with a diagnosis of cancer, right? So they're quite devastating, and they're not wounds that we're going to heal, really, right? So they have a different approach. So yeah, Natalie, why don't you come on up here? We're so happy to have you today.
Okay, so you're a little bit taller than I am, eh? Oh, okay. So I'm French, but I'm going to present in English. So if you don't understand me, Melanie is going to be my translator. Puis si vous avez des questions, vous pouvez poser vos questions en français. And I don't know if any of you remember Wheel of Fortune at the time in Vanna White. So Sylvie is going to be my Vanna White for today. And Sylvie, I forgot the bag behind the table way over there. And Denise gave me the hardest part of the day, so I guess I have to wake you up. So if I see anybody sleeping a little bit, I'll wake you up. Us Canadians, Acadians, we really love to make a noise. So I'm having fun with my clappers today. So oncology is my baby. I've worked in oncology for 23 or 25 years. I did all kind of job in the clinics, chemo clinic, radiation on the floor, clinical trials, all kind of stuff. And then COVID arrived. So I think we all had a little bit of a hard time during COVID. So I said, okay, I need to do something different with my life. And I found it was cheaper to change job than to change husband. So I went and I did the NSWOCC course, and a position was open. So and that's where I've been for the last 4 years. Do I have to move this myself? Yes, okay. So today we're going to do a little bit of the physiopathology of oncologic wounds, the challenges and management of those wounds, and then we'll talk about radiodermatitis and what can we do with that. So squamous cell carcinoma of the skin. So it's a very challenging wound for nursing staff. It's very hard for the patient, for the family. It's disfigurating. Oftentimes it's in part of the body that you'll see head, face, neck, ears. Often smells awful also. It affects the self-esteem of the patient. And it's a constant reminder that cancer is right there. So it's really difficult for everybody. Squamous cell is the second most common type of skin cancer after basal cell. It has a good curable rate, 90% over 5 years. But of that group, 5 to 30% of them will develop metastasis. And when it's at a stage 4, there's less than 10% chance of survival. So most of the oncologic wounds are fungating wounds. The first 2 pictures, number 1 and number 2 on top, are breast cancers with cutaneous metastasis, skin metastatic. And the one on the bottom is squamous cell carcinoma in the upper back. So the wounds kind of look, we call them like cauliflowers. They're all fungating, they're very large, a lot of exudate, a lot of smell. They're hard to cover because they're exteriorated. It's bigger than the body, even like with a shirt, sometimes they're hard to cover. And ooh, my hands are, okay. And it's often a cause of isolation. Patients are scared to get out of home. They don't want to get visitors. So they kind of isolate themselves because of the way they look, the way they smell, or how to cover the wounds. So it's very difficult cancer. So what can we do with that? Because we're not going to cure it. When it's at that point, it's incurable. The only thing we can try to do is to manage the symptoms and the side effects of the leaking wound. So the objective is symptom management. In 2024, the NSWOCC put out Canadian best practice recommendation for topical management of malignant cutaneous wounds, okay? Woo! Went very hard. Ça, c'est les lignes directrices pour les plaies oncologiques. Bon, ça allait mieux comme ça. So I really encourage you to go read it. It's very thorough and there is a lot of them. So we're not going to be able to go through them all today. So I kind of picked my favorites or the one that I find are most important and to go through them with you guys. So the first one is to conduct a thorough wound assessment, wound area, the depth, the height, the type of tissue, is it itching, with the peri-wound, the exudate, etc. So in that aspect, it's very important to have a first impression of the wound. But for oncologic wound, you don't need to measure them or take picture of them week after week after week, because it's just going to be discouraging for the patient because it's never going to get better. So we try to avoid that. There are validated tools for malignant wounds assessment. There's the MWAT-C, which is Malignant Wound Assessment Tool. There's also an odor scale tool that's in the French book from Valérie Chaplin and Reeves. We are not up to using them right now, so that might be my next projects to kind of implement them. Oh my God. The implementation of those special skills or tools to evaluate malignant wound, but we're not there yet in New Brunswick. I don't know if Nova Scotia or somewhere else you're using them, but eventually we'll get there. Number 2 is to perform a holistic assessment. So there's always quality of life questionnaires in the oncology clinics, which are validated, so those are very useful. And most of the oncology clinics in the province of New Brunswick use them, Nova Scotia also, I know. Involve the person with the malignant continuous wound and their support resource, because it's also very hard for the family to see the patients like that, and you try to help and there's not much you can do. And often you'll need an interprofessional team. So we get asked a lot to go to the oncology center and see patients or on the oncologic floor. Educate the person with the malignant wound and their support person when to seek medical attention. So you kind of give them a recipe, give them dressing, they go out in the community, and it's important to let them know when is it time for them to come back to the hospital. Like a little bit of bleeding is normal, a little bit of odor is normal, but if it becomes too much, they can always come back. You have to manage wound odor. It's very debilitating for the patient. Protect the peri-wound skin from irritant or excessive exudate. Select dressing that absorbs exudates and minimize discomfort. And management of bleeding. So with all that said, that's what we have to do. What do you think we're going to do now? So I don't know, but I still have big questions mark in my head, right? So there's a lot of recommendation, but practically what can we do for those patients? Number 1 is teamwork. What does the patient want? What does the family want? So I sit down with them and say, okay, what's your biggest problem now? Is it pain? Is it leakage? Is it you don't want to see the wound? Is it the bleeding? So you decide what's the most debilitating factor that bothers the patient, and you try to work on that one. You can only work on one thing at a time, right? Vanna, you'll need to help me, okay.
So malignant wound have high exudate, very high exudates. So sometimes that's the biggest problem for some of the patients. So we try to manage the exudate. So we have Aquacel, I'm sorry, I'm going to say hydrofibers, but we took the samples that we have in our hospital. So that's why I don't have all of the company sample here. So hydrofiber Aquacel AG is very, very absorbent, and you can put more than one layer on top of it. So that's one thing that can help. We also have all of our super absorbent dressing, like the Mextra. We have the Caramax. We have the Exudry. And the Sorbian also. And there's probably different kinds out there. Like I said, I just took what we had in hand. Just be careful not to mix up the Mextra with the Mesorb, which are both from Molecule, and they're both white and blue. The Mesorb absorbs a bit, but not as much as the Mextra. And with a malignant wound, you really want your super absorbent dressing. As an example, I had a lead. I'm sorry, I don't have the picture because I didn't have her consent yet. She has a squamous cell carcinoma on the forearm. And the biggest thing was that leakage. So when she arrived to me, she was putting a alpha, you know what I mean, the non-adherent pad on top of it. She was changing it herself 3, 4, 6 times a day, getting up at night to changing it. She's an 82-year-old lady. So it took us like a few trial and errors, but right now with the 3 to 4 layers of Aquacel AG, and we put the big Mextra, roll it all around her arm, and keep it in place with the Easy Fix. Extramural goes once a day. So she sleeps through the night. So that was a big positive thing for her. Negative pressure therapy is not recommended, but in some cases for oncologic wounds, we do use it at a lower suction to control the exudate. In that case, an NSWOCC should be involved with that patient. We also can use a Ekin pouch. This is a small one there, but there's a bigger one, or a stoma peril to control the exudate. All right, so the idea is always to control the exudate, no leakage, so the patient can sleep, can eat. It also helps with the odor, and it protects the surrounding skin. Make sense? All right, peri-wound protection. Because of the exudate, the peri-wound often comes moist, irritated, red, denuded. So we want to avoid that. We love the Tena Pro Skin cleansing cream because it's very, very soft on the skin. It doesn't need to be rinsed. It's pH balanced. There's also like the bedside care that's pH balanced, or any soap that's pH balanced is still good. If the skin is still intact, it's not open, you could use a protective spray like the Cavalon, Brava spray, any spray on the market, skin prep. There's spray bottles, there's the tampon and anything. If the skin is denuded, excorié, and it's really broken down, then the Cavalon Advance has an extra ingredient that sticks on wet skin. So you can apply that on the peri-wound and make sure to let it dry for a full 1 minute before you apply anything else. Literature also tells us about duodenum or hydrocolloid. We don't personally use it in our practice, but it's there in the literature if ever you would like to use it. Cavalon Advance, there's also, I think, it's called Marathon from Medline that has the same ingredients that can stick on wet skin. Whoa. Okay, I missed one. Okay. Oh, I guess I'm missing a slide, sorry. So avoid tape on irritated skin, right? So Sylvie will do the demonstration. So we can use like silicone products, like the silicone tape from 3M that's really soft on the skin. Also any safe tack technology. So all the Mepilex border, Mepilex without border, and there's different companies. So all the safe tack is safe to use. And we use the Surgilast. On a-tu la grosse boîte? I'm really sad because I had very nice pictures, sorry. So you know the burn net that we have? So we do, okay, I went too fast. So we do use that. Like sometimes we make it around the head for the patient. We did tank top with that. We use the Curlix also. Curlix has a good absorbance capacity also. So the lady that I showed you with the wound in the back, so I did her like a really fancy little tank top to keep the super absorbent dressing with the Curlix. I did that with the Curlix and she was very satisfied with it. So you use your imagination basically to try to get the dressing to stay on the patient without putting any aggressive tape. So no Mifix, please, no, that takes the skin off. The Brava strip, the elastic strip like Coloplast has and Hollister has, those were great. Right now I have a lady with the wound is on her head. So we shaved the hair, but it's very, very painful. The peri wound, there's no leakage, but it's very painful. We have a hard time to touch her. So I put the little Mipilex without border because it's not draining that much. And then we put the Brava strip around it. And that's the only thing she can tolerate on her head. So odor control. Oh, sorry. That's for another part. So odor control literature will tell us silver, honey, iodine dressing, charcoal dressing that are good. I've tried all of those. No miracles there. So the thing we use the most, is the Flagyl spray or metronidazole. So we're lucky our pharmacy put it in this little spray bottle. We spray it on the wound. It's miraculous. 24 hours after that, you do the dressing changes. There's no smell at all. You could also put it with gel and it would work. Also doing a soak with hyperchloric acid solution. So whether it's Vash or a BioShell, it kind of helps with the smell also. And for the patient that's at home, they can put essential oil. When they're in the hospital, because we're a no perfume policy, we put cat litter underneath the bed. It absorbs the odor of the dressing for other people in the room or when they get visitors. So those are little tricks. So on the oncology floor, we have a really big box of cat litter with all those little Tupperwares that we fill out and put underneath the bed as we need. Pain management. Sometimes the wound doesn't hurt at all, and sometimes it is painful. It really depends on the cases. So we use non-adherent dressing. We have Mepitel, yeah, or Mepitel, there's Adaptic, there's Ergotool, all kind of non-adherent dressing so that it doesn't hurt when you peel them off. Silicone-based dressing or tape, like we've seen. Mepilex Slide, Mepilex Border, the silicone tape, etc. Pain medication prior to dressing changes. You can also do soak with an analgesic solution. So either lidocaine with sterile water, or you could use morphine with hydrogel or just morphine alone. So sometimes we do soak and do the compress for the pain. Sometimes we just irrigate slightly with it. And you know, we talked about irrigation, PSI to clean the wound, etc. If the wound is painful or if the wound is bleeding, you just do a light irrigation. It's all devitalisé, the tissue devitalisé, so it's all dead tissue in there. And oncologic wounds are really vascularized, so you don't want to get them to bleed. So you don't clean as much as you would do with any, like a pressure lesion or something like that. All right, now we'll switch. So any questions about those oncology wounds? We'll take the questions afterward. And we're going to switch our hat to radio-induced dermatitis now. So a little bit of statistic. 45% of Canadians will develop a cancer during I didn't talk about bleeding. I'm really missing slides. I don't know. Sorry, backward. We're going to go with bleeding wounds. I'm going to tell you even if I don't have the slides. So like we said, oncologic wounds are really vascularized, so sometimes they bleed easily. So avoid any aggressive debridement. You could put ice on the wound, that helps. You could put, tranexamic, yes. So cyclocapron. You can either put it directly on the wound, like irrigate the wound with it, so that would help to stop the dressing, or you can do a compress with it. You avoid silver nitrate, is not recommended for any oncologic wounds. And in our toolbox of dressing, we have alginates, right? Caltestat, Silvercell, Biatin, all those alginates that do have a propriété hémostatique that will help to stop the bleeding. And we have Surgifoam and Surgicel also in our toolbox that can help stop an active bleeding on oncologic wounds. So we say to our patients, a little bit of bleeding is normal. Even if you see a little bit of blood through your dressing, that's okay. But if you wake up at night and your pillowcase is all full of blood, well, then that would be a time to call your nurse or your doctor to see what's going on. Now we really switch to radiation-induced dermatitis. So a little bit of statistic. Half of this room here is going to get cancer in their lifetime. And a quarter of the room will have radiation therapy. So what is radiation therapy? Oh, ben là, there's my bleeding. Did Troy do something just to keep me awake because it's the end of the day? Okay. So radiation therapy. It's a higher energy waves to kill cancer cells. So it kills cancer cells, but it also kills good cells that divide rapidly. So our skin cells divide rapidly, so it kills some of the skin cell. Radiation also leads to localized inflammation, microvascular damage, and alteration of basal skin. And nowadays, we have more combination therapy. For a lot of cancer treatment, we're going to have either chemo and radiation or immunotherapy and radiation. And when you combine both therapies, it gives you more side effects, so more radio-induced dermatitis. You can have radiation therapy varies a lot. Like for a palliative case where you give it for pain, it can be 5 treatments. As for a head and neck cancer, it's going to be 35 treatments. For some type of breast cancer, it's 20 treatments. So it's really different. So more treatments you have, and sometimes during that treatment sequence, you need to have boost. So boost is a higher energy treatment given to your breasts or to your pelvic, depending on the region. So that gives even more risk of developing radiodermatitis. In oncology, all of the side effects are graded, grade 1 to grade 4, whether it's nausea, diarrhea, anemia, or radiodermatitis in that case, where a grade 1 is very light and a grade 4 is very severe, life-threatening. So for skin reaction, grade 1 would be a light redness. Grade 2 would be more redness, more severe redness or deeper redness. And a grade 2B, you start to have moist desquamation in skin folds. So here or underneath my arm. At the grade 3, you have moist desquamation in skin fold and surrounding area. So when you have moist desquamation, it's an open wound, right? And you never want to get to a grade 4 because grade 4 are life-threatening, so we don't want to get there. Some sites are more at risk than other. So the breast is more at risk of having radiodermatitis, head and neck cancer, and vulva and canal anal, so perianal cancer. And all of those cancers are treated with combination therapy. So either radiation and chemo or radiation and immunotherapy, which we know will give us more side effects, right? So recently, well, Last time I went, I think it was at the national conference in Ottawa or Calgary, I don't remember. And I went on a presentation on radiodermatitis. I was all excited. Yes, hoo. So I got there and the guy came up front, the doctor that was presenting, and said, well, I hope nobody in here is still using flamazine. And that's what we were using all the time. So I said, okay, I better listen and like put us back up to date. So for years, we've been using flamazine as soon as we had an open wound. So as soon as we had moist desquamation. But there's new guidelines that have proven us that it's time to change our protocols. So last year, the resource nurse from the oncology center, resource nurse from the oncology floor, and myself, we reviewed over 20 different articles, plus our Bibles, like the radiation therapy book. And I reviewed the French book from Valérie and Reeves that we have. And the librarian did this big research to get us all on all the articles for our research. After we collected all the data, we met with the 4 radio-oncologists at our center and we kind of reviewed our protocol. So that's what we're going to talk about from now on. So the number 1 recommendation is to use a corticosteroid cream from day 1 up to day 14 post the end of the radiation treatment. Because when you have radiotherapy, it works while you're having it, but it still works for 14 days after you're done with your treatment. So that's why you have to continue the cream. So this was a big change of practice for us. And it makes sense because we saw that radiation induces an inflammation response, right? So the cortisone cream is going to slow down the inflammation process. And it was decided that we're going to use it on at-risk sites, which is what is recommended in the literature. So perianal cancer, head and neck cancer. As for breast cancer, according to our radio-oncologists, the methods have changed in the last 2-3 years. They don't give as much boost and the treatment is not as long. So we rarely have grade 2 or 3, grade 2B or 3 radiodermatitis. So it was decided that they were going to not prescribe it to everybody that has breast cancer, but only to at-risk patients. And that makes sense to us because it was, from my experience, the biggest radiodermatitis that we had was all with head and neck cancer and perianal cancer. And when a patient gets up to grade 2B, sometimes you have to put those treatments on hold. And when you hold the treatments for a certain period, it has an impact on the survival rate. So we try to avoid that. So you have there's level 1, level 2 evidence in many of the studies that we reviewed. And it doesn't take the radiodermatitis effect away completely, but it lessens it. So people will still have grade 1 or grade 2. And if they do go up to grade 2B or 3, which is moist desquamation, we now see that it happens like in week 5 or 6 of treatment instead of week 3 to 4. So more by the end, so they can kind of tolerate the treatments until the end, which was the objective. Unfortunately, we didn't have like all the data from before, and we should have done like more data collecting to prove our point. But we do see a better outcome in patient and less hospitalization actually for head and neck patients. So I just want to mention the last study, HO in 2018. So this was a corticosteroid cream versus just hydrating cream. You had 12% in the group of cortical versus 20% in the group of hydrating cream. So you see there was a clinical significance for use of corticosteroid. Now, which cream do we use? So all the literature pointed out to mometasone or betamethasone. So we discussed this with our dermatology department, and they suggested to use Desonide. So that's what we're using right now. So Desonide is kind of a newer corticosteroid cream. So maybe that's why it was not included in the research that in the literature that we reviewed. But that's what we've been using since December 2024. So recommendation number 2 is Mipitel film for breast cancer patients from day 1 of radiation until the end of radiation. There was a lot of evidence pointing into the use of Mipitel. It was not, there's a lot of literature with the use of Mipitel on breast cancer. There was only one article from RADS 2019 with Mipitel on head and neck, and that was not statistically significant. And there was no literature for this use on perianal cancer. So that's kind of why we've not been, that didn't go through at our center, because the biggest problem is with head and neck patient, perianal cancer patients, and not with breast cancer. So that's why that recommendation didn't go through for our center. Recommendation number 3 is the use of an antimicrobial cream when there's an infection. So flamazine still exists. There's also mupirocin that can be used, but instead of using it from day 1 of moist desquamation, we only use it when we have signs of infection. So we refer to our stonies and nerds to see if there's signs of infection. That's when we start using it. Silver nylon dressing. So there is different kind. There is the Interdry, there's the Dry Go. They are very useful for breast cancer patients and gynecologic cancer. So patients who have large breasts, we will use it, and gynecologic patients, because it's easy. You take it off, you go to the bathroom, you put it back on. So some people do like it. Some don't, because it doesn't stay good, and some do. In the literature, we also saw some things about aloe vera, candula, medihoney, but nothing was really concluent. It was not statistically significant. Ooh, I got it. All right. Okay, so what's the best treatment for radiodermatitis? Prevention, right? Nobody wants to get it. So lifestyle is a big thing. So we do a lot of education with our patient. To stop smoking, smoking cessation, good hydration, good nutrition. It all helps. Wash your skin with a pH balanced soap. Skin hydration. So literature refers to different creams, CeraVe, Glaxol Base, Lubriderm, or La Roche-Posay. Those are the 4 ones that are most common. Skin protection. Protect the skin from the sun, from extreme weather, whether it's hot, warm, no sauna, no hot tubs. And the corticosteroid cream from day 1 to day 14 post-radiation. So to help our patients, number 1, to help our nurses know what to do with the patients, and to save us some work from all the consults we were getting, we decided to do a little care plan for grade 2B and grade 3 radiodermatitis. So for head and neck patients, and this is half French, half English, I think, but we'll manage. So whenever you have a moist desquamation, you stop the hydrocortisone cream. So you can still put it on the redness around, but not on the moist desquamation. We give the patient a tube of teneprospin soap. So we tell them to wash the region with the teneprospin. Good job, Sylvie. And then we do saline compresses, which that's been going on since I started nursing 28 years ago. So this is still a good practice. We always do skincare 4 times a day. So that's why we have morning, supper, and then the other one is dinner and bedtime. At dinner and bedtime, we do VASH compress, or we say VASH because it's our in-house protocol, but hypochloric acid compresses for 10 minutes. And then we have intrasite conformab, so that's what we use. And on top of it, we put the Mipilex Light. So intrasite conformab, there's also Caracool from Solventum that could be used. So basically, it's a hydrogel with a mesh dressing. It just gives like a soothing effect on a burn. So patients really like that. And When you have a moist desquamation, it's an open wound. So the basic principle of moist wounds still apply for those, right? Moist environment for wound healing. The problem with radiodermatitis, we try to heal a wound without taking out the causal effect. We cannot stop the radiation, right? So it's like swimming against the current. So we try so that it doesn't get worse, so that the patient can finish all of their treatments to give them their best survival rate possible. Then we did the same thing for perianal cancer, right? So again, moist desquamation, you stop hydrocortisone cream on the moist desquamation. You can still apply it if the redness goes further. So there's just a few differences between the two. We added flamazine or any antimicrobial cream because one of the side effects of perianal radiation is diarrhea. So all of the patients by that time do have diarrhea. So you have stools going on an open wound. So it's prone to infection. So we often get infections. So we decided that we would use the antimicrobial ointment right away. And we cannot put Miplex light because there's no dressing that's going to stick on a bum when you have diarrhea 12 times a day, right? So we still put the intrasite conformab. Then we put those little cute mesh panties on top of it. It still has a soothing effect for a bit. When the patient goes to the bathroom, it falls off. But for the time that it stays on, it helps to relieve a little bit of burning sensation. So we started with all this in December 2024. Like I said, unfortunately, we were not smart enough to collect data pre and post, so I don't have anything more than what I observed to tell you. But from our observation, we have less grade 2B and grade 3 radio-induced dermatitis. If the patients have them, it's by the end of their treatment. So we have a lot less patients that have to stop or hold their treatments. We have less consult, which is great. It means that nurses are really doing their care plan. And comments we have from the patient, the hypochloric acid compress and the gel with the mesh, so intrasite conformab, really has a soothing sensation. There was this patient a few weeks ago had a neck cancer, and he was never admitted, so we treated him like as an outpatient. And he said like he would get up 10 times and he was on pain medication because of the burning sensation and all that. And he had really better night of sleep and kind of reduced by half his pain medication after we started all the protocols. So we kind of think that it does help patients. And that's it. So any questions? And are you still awake? Yes, okay. Vous pouvez demander vos questions en français aussi, là.
We have patients that go to the Demont from the Moncton Hospital for radiation. How quickly after they get the radiation would you want the cream on? Because it takes them a good hour to get back. Like, should they be putting it on at the Dumont or should we?
There's no special time. And now, like a long time ago, they said that you couldn't put any cream on prior to radiation. As long as it's put half an hour prior to radiation, it's okay because it's gonna. Yeah, as long as it's half an hour before. So to facilitate the process, that's why we said like morning, dinner, supper, bedtime. So there's no fixed timeline recommended in the literature. The only thing that really changed is that it's not 20 years ago, they said you could not put any cream at all before radiation. And now that kind of changed, just like they said you couldn't put any deodorant, and that changed also. So
I have a couple questions online. Regarding odor, I had a doctor order for mouthwash compress. Is that okay for a wound? Ooh.
I've never used it because I don't imagine that the pH of the mouthwash would be the same pH of the skin, contrary to the hypochloric acid that has the same pH of the skin. And I haven't seen it in there, so I wouldn't say it's recommended. I haven't seen it in all the literature we read.
One more. Do you try to dry up
Oh.
the wound, like Inidine, for
Oh,
example?
sorry, she's talking.
Oh, I'm so sorry.
We do actually have hypochlorous acid in a mouthwash form that does work in healing mouth wounds. So that is a great product that we use a lot. And I don't want to, we've used it personally with effect as well, but we do use that on patients with mouth sores. Yep. Yeah.
But I wouldn't
So
put,
maybe-
like, I wouldn't put Scoville Listerine on a wound.
No. The next question is, do you try to dry the wound up with Inidine, for example?
Inidine is talked about in the literature to control odor. Fungating wound are not the same. They don't have the same process or the same pathology as our normal wound. So I don't think nothing is gonna dry it up, really. You need to absorb the exudate coming out.
Anyone in the room?
It's $5 for you, Emily, to ask a question.
I'll pay you later. It's okay. We, little bit of a different scenario, but we had a patient who was actively dying and had wounds that were quite smelly, and we wanted to use Flagyl. And our ICU doc said, no, we're going to keep them alive if we put Flagyl on. That was about the look I gave him, but I'm just wondering if anyone's ever had that experience or had trouble ordering Flagyl for that reason.
We haven't. No, I know our pharmacy is used for us to order Flagyl. Flagyl just kills les bactéries, là, anaerobic that causes odors. So it. Yeah, so no, I don't think it's gonna give a boost to the wound to, yeah. Mhm. The only thing you have to watch with Flagyl, we talked about the Flagyl spray and about the Flagyl gel. So you don't want to put Flagyl gel on a wound where you're going to give radiation. So you don't want the gel there while you have radiation because that could give a boost. So that's why we mostly use the spray. If it's in a palliative case, then, but also an oncologic wound where they're very, very exudative, the gel is just going to make the wound leak even more, right? So that's why we always use the spray.
What do you use for your spray? Is it saline? Is it sterile water? What kind of bottle do you put it
Could
in?
you send me an email and I'll send it to our pharmacist? Because I really don't know. I'm sorry. It comes in this white little bottle and it's already mixed up for us. And I know there's some community pharmacy that do it also. So basically we give this Flagyl, I don't know if I wrote it down, and the pharmacist does the combination. So we kind of don't worry about it. I'm trying to see if I have the concentration there.
One of the dermatologists recommended to put Vaseline on the cancer wound. Can we do that? The wound we have is not friable and is dry mostly.
Well, if it's dry, you want to leave it dry. You don't want to debride an oncologic wound and you don't want to moisten it because you don't want it to begin to leak, right? So I've never put Vaseline on it. What? But
Can you clarify your question online? Is it the radiation damage or is it fungating?
Cancer wounds.
So
Cancer
fungating
wound, I
cancer,
didn't say.
well, cancer wound, yes, most of them are fungating. Some can be cavitaire, meaning cavity, and some of them are dry. But you don't want to debride them, so you don't want to get the moist environment. You just want to keep them dry if they're dry. So we've never used Vaseline, and it's not in the literature either, nowhere.
Yeah, so we recently had a fungating cancer wound and our doctor ordered the Flagyl like pills just crushed. Is that fine?
It's fine. It's the same thing as the spray. At the last national conference, they were talking about the risk of crushing a pill and mixing it for the staff for nurses and professionals. So that's why in the pharmacy, they have the hut, right? They prepare everything underneath the hut. So yes, it's feasible. Is it recommended? Not really for your safety, for the nurse and the LPN safety. It should be done under the hut at the pharmacy. Yeah, but when you crush it as a powder, there can be fumes that comes up. So if the pharmacy would crush it for you, put it in and then you just spread it on the wound, I think that would be better. It's the idea is that you're exposed to the fumes.
And we actually we had a compounding pharmacy at Moncton Hospital and we lost that. So we go externally. So in Fredericton, there should be compounding pharmacies. And do they have compounding capabilities? Because then they could prepare it or they could go outside source and, you know. Yeah, there's,
Are
yeah.
you in Moncton or?
No, Fredericton.
Fredericton, okay. Because
Yeah.
I know in Moncton, Ford Pharmacy does it for us. Well, in the hospital, it's the hospital pharmacy, but for at-home patient, Ford Pharmacy does compounding.
Yeah. Yeah.
I haven't found anything in the literature about it, but it was presented at the national conference 2 years ago. So that's why I like to mention it for staff safety.
There are other options as well when you're compounding. So if your patient is having a lot of pain, you can actually compound with methadone and it will do some pain relief in those wounds. They'll mix it into a stoma powder, which is a hydrocolloid. So it does some absorbency as well. So compounding can be a wonderful thing and there are resources out there. There's the palliative pearls by.
Well, we were, yeah.
Yeah, I don't know if we.
She's retired, Nicola McPherson. So I don't know the latest. Yeah. So this is just, I'd have to look up the details. I'm on the spot, but yeah, it's a booklet actually, Palliative Pearls. And once you email her, she'll send you the document, the updates annually. And we have it on our palliative floor and there's all like really all kinds of.
Any analgesic will do. Like we use
Yeah.
a lot of lidocaine and morphine because it's cheap.
Yeah.
And it's easy to access. So that's why that's the two that are put in the presentation, but it could be ketamine, it could be methadone, it could be any analgesic.
And I think that's the biggest thing. I think of Kevin Wu all the time. I'll say it depends really. And that's the big thing with malignant wounds is it can change the patient needs day by day. So you always have to have those, what Natalie went over every day, thinking about that. And we're not going to be potentially staying with the same regime every day. It just depends on the patient's needs. Itch happens as well. And when we do compounding, sometimes we'll have an intrasite gel or even stoma powder, right? If it's a wet wound, things like that. So the Palliative Pearls document does have that. I will have to find out if we can.
And the idea, like, don't get discouraged. The wound, you'll never get the wound better. And those like cancer wound, I'm not talking about radiodermatitis. Radiodermatitis, we try to heal the wound, right? And with cancer wound, we try to manage the symptoms. So keep 1 week, the patient problem might be the exudate, and then the next week might be the pain. So you always have to evaluate what's the patient objective and try to reach that goal.
Exactly. Yeah. No other questions? Well, thank you, Natalie. You are the last presenter of the day. I'm gonna be you. Good job.
I want to congratulate Denise for organizing this day.
I didn't do it myself. Oh, Natalie, there's lots of people clapping online for you. I love seeing that. I don't know if you guys can see this online, but yeah. Okay, so I need to find, and I'll probably have to. Oh no, see, double click there. Okay, because then we'll have to scroll through once it pops up, I think. Okay. Screen or slideshow. Yeah. Okay.
I think we've had a really interesting and educational day. Would you agree? I think so. And so As part of the closing remarks, I'd like to take the opportunity to share with you some of the initiatives that we're working on at Nurses Specialized in Wound Ostomy Continence. These are for all nurses, and we want to make sure that you know what is being worked on and what you can get access for to help you working in your clinical practice, and also some upcoming events. So the first thing, I want to make sure all of you are aware that the NSWOCC Advance was rebranded into the Canadian Journal of Wound Ostomy and Continence. And so I did have a couple of copies on the back table, but they're gone now. But if you are a member of the association, this will be mailed to you, or you can access it online. And what we're trying to do is create a forum where Canadian clinicians can publish their papers on wound ostomy and continence, and it is they are peer-reviewed articles. So I think you'll find it very interesting. We're just getting ready to mail our second issue for September. I also wanted to let you know that we've been working in the background, expanding our educational offerings from the Wound Ostomy Institute and Continence Institute. You'll see at the back table all of the different programs that are offered. We have added a paramedic program because so many community-based paramedics are doing frontline care in the home. And in many communities, they don't have enough community nurses to go in, or they want to reduce the number of patients coming into emerge that could have an intervention and then be seen in follow-up by a family physician. We also have a PSW and caregiver course that is available, and it's actually quite active right now. And we just launched a continence management course, and we do have flyers at the back. And we will be launching a wound ostomy and continence course for pharmacists early in 2026. So there are a lot of different programs, and they're all available at wocinstitute.ca. We're in the final stages of a best practice recommendation for wounds in people who use drugs, a harm reduction approach. And this has been led by Lily Baresco and Priyanka Jani, and they've been working with the Harm Reduction Nurses Association and the Ontario People Who Use Drugs. And this will be available at nswoc.ca by January 1 of 2026. We also have, led by Emily Woodgate from Halifax, who is our pediatric community of practice lead. We have the International Pediatric Ostomy Best Practice Recommendations. Emily has collaborated with Emily Dick, who's with the UK Stoma Nurses Association, and they have a whole team working on this best practice recommendation. So you know, take note that these Atlantic NSWOCCs are making an impact on an international basis. We also have a project going on called Wound Dead Space, Wound Packing, Sinus, and Tunnel Care. It's being led by Dr. Kevin Wu and Mary Hill, who is a NSWOCC for Calgary Home Care. This project is well underway. I think it's going to be very relevant clinically, and it will really help to blast some myths that are out there about wound packing. We also have a moisture-associated dermatitis project, which is being run by Kevin Wu and Joshua Morello, who is our Ontario Regional Director. He's based in Toronto, Ontario. And this research is in progress, and it will be available in a document form and a tool on our website in the very near future. We just launched this past week the National Standards of Practice for NSWOCC's Review and Revision. This is a national project. We do have representation from all regions of Canada, including Atlantic Canada. We are funding this project to make sure that we're setting the highest standard in wound ostomy continence across Canada. And once we're finished with this project, we will be starting on phase 2, which will be a national standard of practice for swans. And this will be differentiated from NSWOCCs so that it will be very clear where NSWOCCs are practicing, swans are practicing, and how they collaborate together. And then the last few are, we did launch the malignant cutaneous wounds, and we just got it translated into French. So it is available at nswoc.ca in both English and French. We also are in the final stages of a harm reduction wound ostomy toolkit, which is mainly focused in thermal wounds for people who are living on the street. And it's got lots of pictures so that you can really identify what the unhoused population are dealing with. And we will get that launched by early 2026. And then the last one is the ISTOP, the International Skin Tear Advisory Panel, Skin Tears and Dementia document. We have a research team working on that as we speak, and it will be presented at the next NSWOCC WCET Joint Congress in Vancouver. I also want to make sure you're aware that we do have an Indigenous core program. We launched this in 2018 in the spirit of truth and reconciliation. We are launching a project to develop an Indigenous skin tear classification tool, which is aligned with the ISTOP skin tear classification tool. That will be completed by April of 2026. The Indigenous Core Program led by Bev Smith and Michelle Buffalo are holding a webinar third week of January 26. Everyone is welcome. They'll be talking about health inequity in Indigenous communities. We'll be holding a blanket exercise in April 2026 at the Joint Congress, and they will also be presenting on health inequities at that same Congress. We've also launched a website to house information on Indigenous wound ostomy continence in a culturally safe format. And it's called the Sharing Circle Online. Again, if you have any colleagues working in Indigenous communities, this could be helpful information. And we just finished the first cohort of the Indigenous ECHO program. And that's a community-based education program led by Dr. Gary Sibbald, and Michelle and Bev worked with him to make it culturally safe, and it was launched across the country. And we're hoping to get phase 2 very soon. And then just to finish up, we have Step Up for Ostomy, and NSWOCC is a gold sponsor. And we also have teams of NSWOCCs right across Canada who will be going out and walking with ostomy patients in support of their efforts. And we also have been doing fundraising for Ostomy Canada to support our ostomy patient populations. We're holding a Canadian Pressure Injury Advisory Panel Summit. NSWOCC manages the CPAP group, but they are run independently. Nancy Schuttenbeld, who is here, has been very active in this group, and Sherry McPhee as well has been a major contributor. And this will be virtual and in person. It's going to be held at Carleton University. And Joyce Black is one of the keynote speakers from the NPIAP group in the US. And we also have a patient speaking on lived experience, and we have AI in pressure injury care and how that looks moving forward. And we also will have a presentation on a white paper that is being written looking at pressure injuries across Canada and what recommendations need to be made to the government level. So it's going to be quite an interesting day, and you're all welcome. And then we have a World Without Skin Tears Day, April 9th of 2026. And that will be open to everyone. It's at skintears.org. And we also have a Skin Tears Made Easy webinar, which is November 18th at 10 a.m. Atlantic time. And you can register at skintears.org. In fact, you can join ISTOP for free and get access to all the tools and information at skintears.org. And then our last announcement is our joint congress, which is happening April 24th to 28th at the Vancouver Convention Center in Vancouver, British Columbia. It's called In It Together, Moving Mountains to Create a World of Better Wound Ostomy and Continence Care. We're partnering with the World Council of Enterostomal Therapy, which is the mothership of all wound ostomy and continence on a global basis. And our NSWOCC program is accredited by this group at the highest standard. And so we've been working on this already for about 9 months, and the program is done. It's available through the website. If you go to nswoc.ca, you can click on to the program. We have speakers from across Canada. And again, Emily Woodgate's presentation on the pediatric ostomy best practice recommendations was one of the 5 presentations chosen for keynote. And so that's amazing. And then, of course, we have this amazing education day. And thanks to Denise, you have no idea how much work she put into this in the background with all your volunteers. It's been absolutely incredible. The number of emails, the number of arrangements, and I mean, she put her heart and soul into this, and I really thank you. Yeah, it's all good. Yeah, for next year. So next year, she said, I didn't want to be the one that announced it, but it's that, well, when I went to Charlottetown, this was just before the pandemic, because we were supposed to go there. I kept hearing about this Red Shores racetrack where the NSWOCs used to go to have their conferences and how great it was. So I asked if we could go and see it because I just was interested just to see what it was about. And it's an amazing venue. Saturday, September 25th, 2026 in Charlottetown, PEI.